Fantastic.
Open the room.
I'll be live on YouTube. You can share the link also in the chat and to the to me.
Yeah.
So, Brijesh, we can start now. We're already around 40 people around here.
Want me to start or you want me?
Yeah, you being the moderator of this, you start and I can, or I can start. Okay. Good morning, ladies and gentlemen. It gives me a great pleasure to welcome you all for this first IAN-AOCN AOCP Joint Symposium, which is been organized by the joint collaboration with the pediatric subsection of Indian Academy of Neurology. In last 6 months, Indian Academy of Neurology has tried to have the collaboration symposium with various subspecialty. And I must tell you that all the symposium has been very well accepted. We had joint symposium on epilepsy. We have joint symposium on other disorders, and we are waiting for movement disorder to give the final hit. We also had a joint collaborative session with NSI as well as API. So we are trying to reach out to the maximum members of IAN with all subspecialty to be covered during 1 year. And I sincerely hope that both IACP and IAN president in future continue this tradition at least once a year so that maximum number of people with their interests can be benefited with academic knowledge. With that note, I welcome Dr. Anaita Hegde, currently the president of AOCP, and she can say a few words before Rajesh can take over.
Good morning. Thank you, Nirmal. Thank you to IAN and the Pediatric Chapter of IAN. It's enlightening and a happy thing that the AOCN and the IAN can hold a session together. The topic has been very well chosen, and I think the subjects and the talks will be well received by everybody. I think we start with the session in the morning, and welcome to all the speakers on behalf of the AOCN. Rajesh, I think we can start.
Yeah. I think we should start just a couple of things. Again, I must congratulate the IAN for taking, especially Dr. Nirmal Surya, whose brainchild this is, of his joint collaborative sessions with different organizations in India, which are specialty based. And I think the AOCN being there for the last 10, 12 years, having the largest number of child neurologists in the country, is the right specialty organization to sort of take on this challenge. Now, we have chosen very young and talented, established as well as upcoming child neurologists for this talk on autoimmune disease. As you know, autoimmune disease in children in CNS autoimmune disease is a little different. We have taken the most common ones which we see, and where the manifestations may be different in adults, in children as compared to adults. And I think the format of the program is that first we'll have 2 talks. The first one, shall I introduce the first talks will be followed by 2 talks will be followed by some question answers because they have some common theme. And then the next 2 talks will have, followed by another question answers. And whatever extra time is there, of course, there'll be enough time for questions if there are any more. Shall we introduce the first speaker, Dr. K.P. Vinayan? Can you? Yeah. Dr. Vinayan is no stranger to all of you. He's one of the very well regarded, very well thought of people, child neurologists in India. He's at Cochin. He's a member of several international organizations, as well as has been the convener and the force behind the pediatric neurology subsection of the Indian Academy of Neurology. He's done a lot of work in epilepsy as well as other areas of neurology. And as you can see, there are lots of positions held. His first talk will be The first talk which Vinay will be giving us is an approach on how to deal with white matter disorders, autoimmune white matter disorders, and specifically pediatric MS, a little bit on that. Vinay, please go ahead.
Yeah, thank you, sir. On behalf of IAN Pediatric Neurology subsection, I would like to thank all of you who have joined today on this Sunday morning, especially a Sunday morning, especially if you are sitting at home. It is a very, we are all very slow to start. So we have around 60 people attending at this point. At 10 o'clock means the interest in this program. So without much further ado, I will share my screen and start the presentation. So this is more like an approach talk. I will not be going into the details of each and everything. So yeah, you can share, you can see my screen. No? So the recurrent demyelination in children, this, as you know, this is an evolving field. And there are a lot of things which are happening. The approaches are changing. If you look at the literature 10 years back or 5 years back, the current terminologies have changed. So what I'm trying to give you is a kind of basic, a bird's eye view of when a child comes to you with a suspicion of demyelination, how you can go about, especially the acquired demyelination in children. So we'll start off with a case. This is a 3-year-old girl, and she is presenting with gait difficulties of 3 days. And then she has landed up into our emergency with seizures and followed by irritability. And on looking back, on questioning, they say that there was some mild fever 2 weeks back. And on examination, she has definitely bipyramidal signs. And then she looks like a little clumsy, but you know, in 3-year-old, it is a little difficult sometimes, especially if the child is irritable. So as any neurologist, we would like to see when you get a case like this is to have a kind of tentative working diagnosis, and then put the possible differentials and then work up, rule in and rule out. And then we have to decide on the immediate management options, looking at the short term, especially if there is a risk of ending up in the ICU, respiratory issues, altered sensorium, protecting the airways, lot of other issues. And then what happens is the long-term outcome once we started management, and then what should be the natural course and what should be done to modify that natural course. See, if you look at clinically, this is something like the topic is demyelination for the next 20 minutes or so. So I have tweaked this question. See, but that was a general approach. So when you look at a specific issue of demyelination, the first question is, are we dealing with acute demyelination in the children, or what we call the post-infectious demyelination, or an acute disseminated encephalomyelitis, or is it something like a new antibody disease, which is the first episode of that? And then with comes the kind of questions afterwards, which depends on whether it's a demyelination or not. So the issue here is, at this point, the central demyelination disorders has evolved a lot. Even though we say that it is actually due to damage or loss of myelin, and then there is a pathological evidence. In a clinical practice, we never go for a pathological evidence to diagnose demyelination. So it's a presumed, we take it for granted that it is inflammatory immune, because we treat with specific drugs, anti-inflammatory drugs or immunomodulatory drugs, and then we get response, and then we'll take it for granted that it is actually demyelination. So it is, at this point, it is more of a clinico-radiological syndrome, no pathology involved. And nowadays we have some immunological markers, especially the MOG antibodies, and then NMO came into the picture in a big way. We have some immunological markers to go by. But otherwise, these syndromes are clinico-radiological syndromes. So MRI helps. MRI is the key diagnostic marker at this point, or the diagnostic investigation at this point. So we have named syndromes. So as always in pediatric neurology or in neurology per se, we have named syndromes and we have non-syndromic, because many times the kid or a given patient will not fit into any of these named syndromes. And then we may have to put like, or some way out is in clinical practice, we skews into the one of these pigeonholes, or we will try to say the other option is you keep it open, okay, and say that at this point it's not clear. But these are the named syndromes at this point. And then we have classical MRI pictures of this. I will come to that later. But one thing which is very clear, there are specific areas involved in white matter disorder. So primary thing is these are demyelination means wherever myelin is there, it is there with the white matter is the maximum affected, but you can have gray matter involvement also in many of these disorders. And then the MRI patterns are evolving. So some of the things, so this is the first thing, first row is the brain MRI of multiple sclerosis, and this is the spine MRI of multiple sclerosis, which is showing that short segment eccentric lesions. And this is the Mogart syndrome, which Vishal will be discussing in detail with a large confluent lesions. And this is the NMOST picture with the long segment transverse myelitis with a significant cord involvement. So again, come to the question of acute demyelination. The problem here is, as I already told, we are not proving it as demyelination by pathology. So you can have many DDs which will look like involvement of this white matter tracts. So the list is endless. See, the thing is, at some point our approach was you rule out everything and then end up with our diagnosis starting with endocrine, inflammatory, especially the infectious disorders. It is very difficult sometimes, the viral encephalitis group. And then we have we know that the metabolic disorders like mitochondrial disorders, which can present with an infection triggered white matter involvement. And then we have this, when you look at the MRI picture, you have in especially the pediatric practice, the issue is of the genetic hypomyelinating or the dysmyelinating disorders, where you have the differentiation is in an acquired demyelination, that is, we call it as demyelination, but the other one is genetic with a that can be triggered by infection. And then you have other DDs like vascular disorders like CADASIL, which can also have significant white matter involvement. So you put it, this is in a given in an ICU setting or in an emergency setting. These are the major DDs when somebody is coming with an acute suspected demyelinating episode. So we have to rule out infectious diseases and then metabolic disorders and then some vasculopathies. But in a given patient, especially we know that monophasic demyelination in small children is very common. So we don't have to think of all these possibilities unless you have some kind of unusual picture. So that means that unusual picture comes from the knowledge of what is normal. So when you have a 4-year-old child with a history of fever coming with an encephalopathy and then MRI showing white matter changes, then the chances of that being a monophasic demyelination like an ADM is very high epidemiological. So that the epidemiological thing also comes into picture here. So this is a good review. So anybody who is interested, if you have not seen this review, I will recommend you or to go through this. Gives a kind of all the possible the mimickers of relapsing demyelinating syndromes in children based on MRI. So as you can see, the MRI picture of mimics can look similar, especially if you have a diffuse confluent lesions like this. You can see that this is a hemorrhagic ADEM, hemorrhagic leukoencephalopathy. This is a mitochondrial disorder. This one was a giant axonal neuropathy picture. So all these things are from that paper. You can go through that. And then this is a child with SSP with a white matter lesion, and the NMDA encephalitis with a very minor white matter lesions. And then this is a glioma child which is presenting with seizures. So the point here is the white matter lesions in children can be confluent and the mimickers are different, and it can be discrete like in MS. And then you can see that this is a child with CADASIL, and this is a child with incontinentia pigmentae and the migraine changes here. And this is the HSP child with that ear rustling sign. So but the clinical presentation can be different, but when you get an MRI, you can get, and especially when you see children with non-specific white matter hyperintensities, that's also very common in children. And if you look at the mimickers in the spinal cord, you can have long segment lesions and short segment lesions. Long segment lesions can be infectious like this rhomboencephalitis, ascending myelitis, and then you can have infarctions and some metabolic disorders like biotinase deficiency. This is a child with biotinase deficiency. And this is a child with fibrocartilaginous embolism with an infarct. So the clinical presentation can be different, but the MRI picture may look very similar. And the MRI can be, especially in MS, you can see that it can be short segment lesions, and the mimickers can be different, and it can be again myelitis. This is a child with CMV myelitis, and this is a child with HLH, and this is a child with this neurofibromatosis, which can have a kind of high intensity white matter lesions. So when you get this child, whatever be the treatment, usually we treat with steroids, and then depending on the severity of the situation, we will give IVIG. But the next question is when there is an improvement or the child left with a residual deficit, the question is what is the chance of recurrence, and can we predict the recurrence chance from the beginning? So that is the really difficult part of the issue, because of the lack of population-based data from our population or our part of the world, and also the specific issues of infections and other related issues. So generally we can say that there are, especially in children, so compared to the adult, the real issue is we have this syndrome of ADEM, which is a very highly prevalent in the community, and then it is a monophasic illness unless proved otherwise. And then you have the clinically isolated syndrome of demyelination, and the main difference between these two is the presence of encephalopathy. And the relapsing disorders are now at this point, this may also evolve with time. We have the relapsing demyelinating disorders. One is the classical one is the multiple sclerosis, and now this antibody or antibody as a marker disorders like the NMO and MOGAD is coming in a big way. Especially the MOGAD has taken over the pediatric demyelination area in a big way in the last few years. And then we have this controversial entity of multiphasic ADEM, which is itself as a kind of probably in the near future there will be newer terminologies for this, or newer diseases will come from this. Okay, so this is the 2012 consensus definition of ADEM. So what is it? The most important thing is the dissemination in space. That means it is a polyfocal illness, and it's a CNS event. And the thing is, it is a, so again, this is what I was emphasizing. It is a presumed inflammatory demyelinating disorder, because it is not we can't prove it without a pathological evidence. But most of the time, we take it for granted that it is a post-inflammatory or changes or an inflammatory change. But there are some studies which have shown that there are actual viral markers and an infectious component in many of these ADEM lesions. And the most important thing is encephalopathy that cannot be explained by fever. This is the most important clinical marker which differentiates a patient with a recurrent demyelination versus a monophasic demyelination. And for the MRI, since it is a clinical radiological syndrome, the main thing is there should not be any new MRI findings 3 months or more after the onset. And brain MRI is normal during the acute phase with typical, abnormal and with the classical MRI picture. So there is, even though we say ADM is monophasic, but there is a multiphasic acute disseminated encephalomyelitis. This is what I was trying to tell. There is a new event of ADEM in the same area or in a different area, and then it should have all the features of ADEM. That means the encephalopathy should be there, and the only thing in the newer criteria is the steroid withdrawal is not taken as a significant criteria here. So the main thing, the point which differentiates, as I already told, is type of lesions. But type of lesions, especially since the next talk is coming up on MOGAD, it is many of these cases are going into MOGAD. But the main thing is large white matter lesions with deep gray involvement. Coming to the clinically isolated syndrome, is one thing is a kind of what we call a tentative entity where there is no encephalopathy, but there is a CNS demyelination syndrome, which is a site-limited syndrome, or it can be features of the main thing is the baseline MRI should not show the features of MS. So it is something like a kind of a bridging diagnosis, where you feel like this may remain as an isolated syndrome, but many of them can convert to a recurrent demyelination in future. So the classical one of the things are site-specific disorders like transverse myelitis. Again, it is many of them may turn out to be, especially after the introduction of MOGAD, so many of them are kind of coming out to be an antibody-related disorder. So coming to the last part of my talk, the multiple sclerosis issue in children. Sorry, before that, NMOSD, I'm not covering in detail, but again, I wanted to tell it here that NMOSD is again an antibody-related disorder, and the closely related to the MOGAD thing, because both are having a clear biomarker, and then this syndrome is going to evolve. But overall, the prevalence of NMOSD in children is much less compared to adults, not like MOGAD. So now the question is, at this point, when a child comes with a demyelination, what is the risk of converting to MS, and whether we can call it as multiple sclerosis at that point itself? We have standard criteria here, and before that, we have to understand that what is multiple sclerosis. Again, at this point, multiple sclerosis is a clinico-radiological syndrome, which is with a multifactorial etiopathogenesis, because we don't have a single unifying antibody at this point for this. The mechanisms can be different, and probably there are more syndromes evolving from this multiple sclerosis dimension. And the key thing here is we have to differentiate this dissemination in space and time with accrual of disabilities. And at this point, this dissemination in space and time, previously it was mostly on the clinical criteria, and we were waiting for the disease to evolve. But since we have definite treatment modifying, disease modifying treatments now, we have to diagnose this as early as possible. And for that, at this point, the most important biomarker is MRI. So what is the criteria? Again, 2012 Pediatric MS criteria says that it should have either you should have 2 or more CIS separated by 1 month interval, and which involves which has got this dissemination on space with the involvement of multiple areas, or you have to have 1 CIS and with the 2010 McDonald's criteria showing that there is a dissemination in space because of the multiple areas of involvement in the periventricular, juxtacortical, infratentorial, or spinal cord. And then there should be a new lesion later when you do a repeat MRI, or the same MRI which shows that there is the dissemination in time based on the McDonald's criteria, which I will be covering in the next slide. Then if you have a first ADM attack, at this point, it is not considered as a chance of demyelination. MS is very low, but unless it is followed by 1 clinically isolated syndrome 3 months after the symptom onset. So if it is occurring within this 3 months, it is a little tricky to call as MS. And it all depends on the conversion rate in the population, the kind of the the countries involved, and then the population data. A lot of things comes into picture when we are calling something as MS, because we don't have a clear biomarker at this point other than the MRI. So what is this McDonald's criteria? We have the 2010 criteria and then the revised criteria. Revised criteria is the 2017 criteria is the current thing. What they have changed is, except the main thing in the DIS, that is dissemination in space, is this the cortical lesion can be considered here according to the 2017 criteria. So it should not be only just a cortical, it can be pure cortical lesion. And the other thing is asymptomatic and symptomatic. Here the symptomatic cases, symptomatic lesions were excluded in the 2010 criteria. But here the 2017, it is both asymptomatic and symptomatic can be taken together. And the other thing for that is for the dissemination in space, but for the dissemination in time, one major difference between the McDonald's tests 2017 and 2010 is this involvement, the introduction of the new one, that the presence of the oligoclonal bands, which has come as a criteria. So if you have a oligoclonal bands along with one lesion, then you can take it. Or the other thing is you can have a the associated gadolinium enhancing lesions. So that can be again symptomatic. So here the only asymptomatic gadolinium enhancing lesions are taken as the DIT, but here both symptomatic and asymptomatic can be taken. So that means this has become more sensitive. So they are adding more criteria, and this is the old Posser's criteria. If you look at the old timers, will remember this, because this is one of the oligoclonal bands was one of the criteria for the laboratory supported MS in long back. So this is again the same thing which I have highlighted again. That is the main difference in 2017 is the oligoclonal bands, and then the involvement of symptomatic lesions, and the cortical lesions can be used to fulfill the MRI criteria. So how is it faring for the pediatric onset MS? There is a large study which looked at the comparison between McDonald 2017 versus 2010, which showed that 17 is more sensitive but less specific. That means you pick up cases more at the baseline, but the chances are that you can have false positives, and that depends on. So that is why the committee recommends that when you have this thing should be considered in relation to the type of patient, and especially in children, it should be a little you have to be a little careful in using this 2017 criteria. And the other thing is this study has also shown that if you have the first diagnosis of ADEM, then this 17 criteria will have more problems. So you have to be a little more careful, but now the current trend is to use the 2017 criteria, because that's the best at this point. There might be more revisions. So again, coming back to the MRI picture, so I'm not going to deal with this in great detail. Every textbook will give this, the specific type of lesions. The MS lesions are more ovoid, and the the MOG lesions are more tumefactive and poorly demarcated lesions. And multifocal, this ADEM now is the newer literature. We don't know how much time this ADEM will remain and how many antibodies will come out of that in the near future. So again, the literature is going to evolve in future. So at this point, you can read this and then understand. So again, spinal cord, you know that MS lesions are discrete, multiple, cigar-shaped, and for the MOG and ADEM, they are large, long, extensive transverse myelitis, and the MOG antibodies will have central lesions also. That means the white matter, gray matter involvement also. And optic nerve, the main difference is the MS is a short segment lesion, and the MOG, which involves the long segment, and MOSD also is a long segment lesion, bilateral. And the chiasmal involvement is one thing which differentiate the MOG antibody. So that means the MOG antibody tends to involve more anterior rather than the posterior involvement. So this is again looking at the different presentations and then try to differentiate in the MRI. Discrete white matter lesions, I have already told. Confluent lesions are cortical, subcortical is mostly suggestive of MOG-AD, and periventricular is more MS. And paramedian white matter lesions are more acroporin or related NMOSD. And the short segment lesions are mainly MS or then longitudinal extensive lesions are more MOG antibody or idiopathic transverse myelitis or that kind of lesions. And optic nerve, you know that relative sparing that I have told, optic chiasm is MOG antibody. Again, if you look at when you specifically look at children, what are the chances of to identify that there is a chance of MS? One most important thing is the type of lesions, which is perpendicular to the long axis of the corpus callosum, which is clearly suggesting MS. And the presence of black holes and all usually not seen in the first episode of lesions unless it is a very florid MS. And then the periventricular lesions, and then the main thing is again the hypointense lesion. Many studies have shown that if you have a hypointense lesion, the chance of MS is high. So now the question is, if we cannot diagnose this as multiple sclerosis at the baseline, what is the chance of this child converting to multiple sclerosis later? So there are several things which are looking at the first episode of acquired CNS demyelinating syndrome, that is the ADS, which we say in children. So what are the chances of multiple sclerosis? So there are several things. So if you have a CIS-like presentation, any demyelination, you can say that the first and the foremost thing in many studies is the encephalopathy part. So if you have a clear encephalopathy, then the chances of developing MS is very low. Compared to that, if you have polyfocal signs, female sex, and especially the older age, that means the post-pubertal age for the first time presenting, the chances of MS or a relapsing disease is very high. And if it is a first episode of ADEM, the protecting things are again the young age. But if you have a family history of inflammatory demyelination, and if they have a previous history of optic neuritis, or presently there is an optic neuritis, or the child improves without any sequelae, or dramatic improvement response to steroids, with that is something like a melting away. So you have to be a little careful. And first episode of transverse myelitis, the most important thing which differentiates against MS is the time to the peak deficit of less than 24 hours rules out a chance of MS. And we have a clear evidence of infection in the history of optic neuritis. That is a point against MS. And then the chances of recurrence is very high when you have a bilateral sequential or recurrent optic neuritis, or bilateral or unilateral optic neuritis presence of. So this I will say that this studies are mostly before the MOG antibody era. So many of these things can be actually converted. Now we can call it as a MOG antibody disease. So the last part of my talk is whether we can modify the disease course in children with a recurrent demyelination. As you know, if you look at the pediatric MS literature, especially the treatment, the disease modifying therapies, apart from the acute treatment of the relapses, we have several first line therapies and several second line therapies. But if you look at the literature, we can say that only the treatment which has got a clear pediatric study is the fingolimod, and that is approved by the FDA in pediatric practice, and that is an oral drug. I'm not going to the details of each and every drug here because this is an overload drug. It will take almost one day for covering all these things. And the other thing is the first line therapies, even though there is no clear studies, it is mainly by extrapolation from the adult literature. We have interferons and glitazone which can be used in children. And the teriflunomide, there is a study which has been completed, the TerriKids trial, which is the results are going to be out. It is mainly it is a positive study. And then the infusions in the second line therapies, the standard infusions are Rituximab, Antigen, and Natalizumab. And the oral drugs are the newer drugs are the siponimod and ofatumumab is infusion. So this basically, you know that what they do is the anti-CD10 20 immunosuppression and immune depletion of the B cells. So each of this has got its own advantages and disadvantages. So at this point, there are some studies going on with alemtuzumab and ofatumumab. So probably there will be more literature in the near future. And then pediatric MS is coming into the rare disorders at this point, and there are specific studies going into pediatric MS. So this is in a nutshell, the different the trials with the newer drugs. The Paradigms trials are out. It is a positive trial, and the Rickets is going to come in the near future. It is almost completed, and the alemtuzumab, the LEMKITS trial is recruiting at this point, and there are new trials coming with ofatumumab and siponimod. So at this point, if you have a clear MS, the problem here is when you have a low incidence in the community, as a physician, we are always worried because of this inherent stigma against MS, and then the chances of the long-term issues. So the overall, the term of MS is much less used in recurrent demyelination thing in our country. But I think we may have to change that tendency and try to diagnose MS as early as possible. And at this point, the approach, this is from US, this is the standard way of stepping up approach, starting with interferon and going into the second line treatment, depending on the response. And then we know that since the MOG antibody came into the picture in a big way, the next talk is that we are using more and more rituximab and other things in our population. So probably there are some studies with rituximab, and the current pediatric guideline also gives that rituximab may be a good option, but in the adult literature also it's an off-label at this point. Probably rituximab may be an option, a cost-effective option in our population. So that completes the agenda for the day for this session, and I think this is the next talk is immediately on the anti-MOG antibody syndrome, which is actually a continuation of this talk. Thank you.
Thank you very much, KP. I mean, it was a very comprehensive and a very practical approach to this subject. I think we'll take, as I mentioned before, we'll take talks. I mean, we'll take the questions after the first two talks, which are similar. Just please, I encourage all of you all to keep sending your questions and comments as you hear the talks, so that you don't forget, and put them in the Q&A. So I'd like to introduce a second speaker, Dr. Vishal Sondhi. Yeah, he's going to be speaking on MOGAD in India, and he's very well-known child neurologist from Pune. He's a professor at the Armed Forces Medical College, and I think it is DM from Ames Pediatric Neurology. And his areas of interest are basically very much, besides clinical neurology, neuroinflammation, and I think he's the lead author on a very, not yet published, but we've done a sort of nationwide survey on MOG, and he's the lead author on that, and of course a lot of publications. So Vishal, please go ahead.
Thank you, sir, and thanks to the organizers for inviting me over, and thank you, sir, for the kind words. I'll just try and share the screen.
Yes.
Is my screen visible, sir?
Yes.
Yeah.
Can hear you perfectly.
Yeah. So we'll jump right in from wherever Vinyan sir has left. And as he said, it's a continuation of the demyelination spectrum that we have been discussing. So we will start with the cases. So first, and then we will go into deciphering what MOG is actually. So this was a 6-year-old girl who presented elsewhere initially with complaints of headache, seizures, and altered sensorium. And she underwent a CSF, which showed around 150 WBCs, normal glucose, normal proteins. They did an MRI. We didn't have the pictures, but it was reported as leptomeningeal enhancement. And rightfully so, they managed it as viral meningitis. And the kid also recovered completely in 7 days. Everything was happy. But about a month later, again, she developed altered sensorium, and this time she developed hemiparesis along with that. MRI this time showed large fluffy shadows. There was no leptomeningeal enhancement. Again, went back to the same doctor. He managed this at ADEM with a IV methylprednisolone at 10 mg per kg per day for 3 days, followed by 4 weeks of steroid in gradually decreasing doses. She was again good for about 2 months, and this time she presented with, again, fever for 2 weeks. And when she presented to the hospital, she had fever running. Along with fever, she also had altered sensorium, incessant vomiting. CSF showed, again, pleocytosis, lymphocyte dominant, normal glucose, normal proteins. MRI showed an increase in the size of lesion, new lesions had appeared. And this time she was managed again with a multiphasic demyelination with IV methylprednisolone and steroids. 2 months later, she again relapsed, this time with a history of fever, altered sensorium and seizures. MRI showed similar large fluffy lesions, and this time she underwent MOG, an MOG assay, and the MOG turned out to be positive. She was managed with multiphasic demyelination with IV methylprednisolone, along with IVIG, and gradual steroid taper over 6 months. So this is the typical picture of demyelination, which even in the previous talk, it was being highlighted again and again. Encephalopathy in various forms, in the form of altered sensorium, seizures. But the unique thing over here was that the CSF was continuously showing pleocytosis. Initially, there was leptomeningeal enhancement also, which kind of triggered the physician to think of it as an infective etiology. And it was only later on in the course. Now, looking retrospectively, it all looks very simple that it was MOG all the way around. But at the first instance, with leptomeningeal enhancement, at the second and third instance, with the child presenting with ongoing fever and altered sensorium, one is bound to think that we are possibly dealing with an infective etiology. Okay, this has already been covered, but what I want to highlight is in children less than 10 years who present with ADEM, almost about 2/3 of them will have MOG positivity. So almost 2/3 of children with ADEM overall may turn out to be MOG positive. So that is the rate of MOG positivity in ADEM in children less than 10 years of age. We come to the next scenario. This was a 12-year girl. She had headache, vomiting, given some domiciliary care. A week later, she developed visual impairment, first in the left eye, and then within 12 hours, she developed visual impairment in the right eye. On examination, she was able to count finger at 1 feet. Fundus examination showed papilledema with peripapillary hemorrhages. Another day or so later, she developed altered sensorium and seizures. Underwent a CSF, which showed more than 200 WBCs. Glucose proteins were slightly elevated, touch and go type 48, but glucose was normal. MRI showed enhancement of bilateral optic nerves, and this enhancement was involving not only the nerve, but also the sheath around the nerve, as well as the fat around the nerve. The rest of the brain also showed fluffy shadows. This time she was treated as tubercular meningitis, though there was no contrast enhancement, not that we could see, managed with ATT and a short course of steroids. The child improved with this initial management. 4 months later, again went back to the same doctor with bilateral optic neuritis. It was interpreted, the MRI showed resolution of the brain lesions. It was only the optic nerves which was involved. So it was interpreted as, or told to the parents as improvement in the condition of the child with resolution of the brain lesions, and only the optic nerves are involved, and no immunotherapy was given. She came to us with a relapse of left optic nerve. In fact, she had already been reported elsewhere with left optic neuritis, and then came to us and was already on monthly IVIG. Serum MOG tested at this point of time was positive. Another 6 months later, she presented with ADEM. And this time we had to put her on Rituximab because she had relapsed on IVIG. So this is another way in which MOG can present. So the first one was just ADEM, encephalopathy, focal neurological deficits. This was optic neuritis with a high CSF WBC count and optic neuritis later on relapsing as ADEM. So optic neuritis and MOG, so MOG positivity is seen in about 15% of all optic neuritis, so 1 in 6. So this is not pediatric specific data. So this is all optic neuritis, about 1/6 of them, 1 in 6 will have MOG positivity. But the important features of optic neuritis when they're associated with MOG is about half of them are bilateral. Half of them will keep on recurring again and again. So if a child keeps on recurring, coming back with optic neuritis, it's quite likely that he's having a MOG positivity. 80% of them are likely to have papilledema. This is in contrast with MS and with NMOSD. So if you're getting a child with optic neuritis who also has papilledema, it is very likely that the child may be having MOG positivity. In fact, earlier we used to have an argument with our ophthalmology colleagues that it is possibly papillitis and you're reporting it as papilledema, but now the data is coming out. If you're having optic neuritis with papilledema, it is likely to be more positive than anything else. And about half of them will have enhancement, not only involving the optic nerve, but even the tissue around the nerve, the fat and the neural sheath. And they typically have a severe vision loss at onset, but subsequent recovery is usually very good. Okay, the third scenario is of a boy who earlier had fever, cough, and cold, and thereafter presented with weakness of both the lower limbs and urinary retention. MRI showed longitudinally extensive transverse myelitis involving about 4 or 5 segments, thalamic subcortical lesions. CSF showed, again, close to 250 WBCs, normal glucose, proteins were slightly elevated, oligoclonal bands were negative, aquaporin 4 was negative, and MOG was positive. So this was a phenotype of NMO spectrum disorder, where aquaporin 4 was negative and MOG was positive. So MOG positivity is seen in about 1/3 of all NMOSDs who are seronegative for aquaporin 4. This kid was managed with methylprednisolone and IVIG, no improvement, underwent plasma exchange, partial improvement, and then was kept on rituximab. So as mentioned earlier, all the aquaporin 4 seronegative NMOSDs, about 1/3 of them usually end up having MOG positivity. So what is MOG, which has been presenting as encephalitis, myelitis, optic neuritis? So MOG is it's an acronym basically for myelin oligodendrocyte glycoprotein. As shown in this picture, it's a transmembrane protein with a portion of it jutting out of the cytoplasm of the myelin and the other portion going in. It is a member of the immunoglobulin superfamily. And along with myelin basic protein and proteolipid protein, these are all components of myelin sheath. And as the name suggests, myelin oligodendrocyte glycoprotein, it's a glycoprotein which arises from oligodendrocyte and forms part of the myelin sheath. Overall, it comprises of less than 1% of the complete myelin sheath, but most of its epitopes are highly immunogenic. Hence, we hardly hear of disease having antibodies against myelin basic protein or proteolipid protein, partly because they are intracellular and partly because they are less immunogenic. The possible functions of MOG, it helps in adhesion of the myelin fibers. It helps in keeping the myelin intact around the axon. It helps in regulation of the microtubules of oligodendrocyte, which helps further in formation of the myelin and addition of the myelin. And to some degree, it regulates the interaction between myelin and the complement system, which actually works both ways, because this also becomes the way in which MOG destroys the myelin. So these are the functions of myelin. And as said, it's highly immunogenic, and these anti-MOG antibodies are the reason why this kind of demyelination takes place. But for a very long period, it was thought that are these innocent bystanders, or are they actually pathogenic? But now all these pathology reports the brain biopsy reports which have come in from in different research areas have shown that high titers of MOG are associated with complement-mediated destruction. As shown in this cartoon also, it is the complement, the antibodies bind to complement, which in turn lead to disintegration of the cytoskeleton. So the oligodendrocyte-based cytoskeleton disintegrates, which leads to disintegration of myelin and leads to demyelination. So these are no longer considered to be innocent bystanders. They're more and more recognized as playing an active part in the demyelinating event. But this MOG antibody assay is actually not new. It was first developed in 1989. In fact, the first paper which came out was in 2003, came out, and there were some very eminent authors involved in this in a very eminent journal, where they said that MOG is a predictor of occurring of multiple sclerosis. So if in the first episode MOG is positive, then it is likely that later on that individual is likely to develop MS. A couple of years later, another set of very eminent authors in the same eminent journal reported that there's no relationship between MOG and MS. Now, there was nothing wrong with the methodology of both the papers. It was just that the assay which was being used was different. Over the years, they kept on making the MOG assay more and more specific. Later on, it was against certain specific epitopes of MOG. Later on, it started involving the whole MOG structure. They made it cell-based. Rather than IgM, they went to IgG. Then within IgG, they went to the subset of IgG, that is IgG1. And a lot of this work took place in Oxford. And currently what we are using is more of a cell-based assay, IgG1 cell-based assay. Another point which came out over all these 2.5 decades of research was that MOG antibody is basically peripheral in origin. There's hardly any intrathecal production of MOG that takes place. So if one has to assess MOG or one has to perform MOG assay, it has to be done in serum and not in CSF. CSF will not yield as good a result as in serum. So we started with MOG as a biomarker for MS, and about 1.5 decades later, in Nature, it was reported that if it is MOG positive, if the patient is MOG positive, then the chances are that he will not develop MS. And this odd may keep on changing with the type of MOG assay that is being done. The best results are seen with cell-based assay, which is immunofluorescence-based, but cell-based assay, flow cytometry-based, or radioimmunoassay are equally as good. ELISA-based assays are weak in differentiating between the two conditions, but even those assays currently suggest that if the patient is positive for MOG antibody, then the chances are the demyelinating event which the patient is having is likely to be non-MS than MS. The other confusion which frequently takes place, especially with the NMO spectrum disorder, is we end up doing both aquaporin 4 and MOG simultaneously. This was again a huge study which got published about 2 years back in JAMA, where they looked at about 15,500 patients serum, and they found that both MOG and aquaporin 4 were positive just in 20. So less than 1%, less than close to 0.1% patients had positivity both for MOG and aquaporin 4. And even in those 20 patients, they reported that those patients had very high titers of aquaporin 4 and very low titers of MOG. So if you find a patient who's positive both for aquaporin 4 or MOG, then the chances are that the patient has aquaporin 4 related disease rather than a MOG related disease. Now, with this background, coming to the different phenotypes, we saw a few phenotypes right at the beginning, but again, to reiterate, so MOG antibody associated disorder can present with optic neuritis. And this optic neuritis is usually bilateral in nearly half the patients, recurrent in nearly half the patients, and many of them are actually steroid dependent. Once again, I've heard it, I've learned it the hard way that if the patient has papilledema with optic neuritis, the chances are he or she is going to be MOG positive. If the patient has peripapillary hemorrhages with optic neuritis, the chances of the patient is likely to be MOG positive. On MRI, if it is again a bilateral disease, it is likely to be MOG positive. If the lesions are longitudinally extensive, involving long part of optic nerve, involving nearly 50% of optic nerve in front of optic chiasma, then it is likely that the patient should be MOG positive. And 50% of MOG positive optic neuritis are likely to involve the sheath as well as the fat. Now, if the patient has MOG positive optic neuritis, the chances are he or she is going to do good. So over here in this Kaplan-Meier, the black line right at the top is MS-related optic neuritis. The pink one is MOG-related. The fluorescent green one is the double negative, which is negative for MOG as well as aquaporin 4, and the blue one is NMO-related. So both MOG and MS-related optic neuritis, they generally tend to do well. The chances of developing severe visual impairment is very less. So less than 5% or maybe 5 to 10% are going to develop that. But if the patient has aquaporin 4 related optic neuritis, the chances are he or she is going to lose vision gradually over years. Over 10 years, just about 10% will continue to have good vision, and rest 90% are going to develop severe visual impairment. So having a MOG positive optic neuritis is actually a good news for the kid rather than otherwise. So this we have already covered a couple of times, so I'll not go into details again. The other phenotype associated with MOG is transverse myelitis. Now, like any other transverse myelitis, it can have a subacute onset of paraparesis or quadriparesis, depending on which cord segment is getting involved, with involvement of neurogenic bowel and bladder. But in MOG-associated transverse myelitis, conus involvement is more common. And the severity of myelitis is much more than it is seen with MS, and up to 1/3 of them will be non-ambulatory at nadir of the disease. And many of them may occur in conjunction with involvement of other regions of the CNS. So they may have ADEM with transverse myelitis or optic neuritis with transverse myelitis. So these kind of combinations are well known with MOG-associated transverse myelitis. MRI features, usually they show involvement of more than 3 vertebral segments. The lesions are located centrally, as shown in this image. The lesion involve mainly the central part of the spinal cord, and they form a typical H sign where the complete central part of cord is hyperintense, and in the sagittal section they will have more than 3 vertebral segments involved. And the involvement of conus is more common in MOG than with NMO and other disorders. So the MOG phenotype of transverse myelitis typically is like seronegative NMOST with H sign in the axial section and the longitudinally extensive transverse myelitis in the sagittal section. The third common phenotype is ADEM, which is actually the commonest phenotype seen in pediatric age group, and about 2/3 of all children with ADEM turn out to be MOG positive. Now, the typical feature is that many of these ADEMs who turn out to be MOG positive have prolonged fever, usually lasting for 2 weeks, 3 weeks when they come up. And even at the time of presentation with ADEM, they usually end up presenting with fever. So it is not that the fever has taken place 2 to 4 weeks back, which is classically with ADEM. So they come with ongoing fever and turn out to be MOG positive encephalitis or encephalomyelitis. Another typical feature is many of them come with incessant vomiting episodes. We haven't seen this at our center, but it has been reported extensively, and in the data that we are accumulating, it comes up as a major manifestation in many of these kids who come with incessant vomiting episodes. They are managed as acute gastritis initially, which become encephalopathic, and then they turn out to be MOG positive. So apart from ADEM, there is another encephalopathy phenotype, which is reported more and more common nowadays with MOG, and that is of cerebral cortical encephalitis. A quick overview on that: many of these kids present with seizures, aphasia, depending on which lobe, the dominant or the non-dominant lobe is getting involved, focal neurological deficits mimicking stroke, headaches, disturbing sleep, headaches, almost mimicking raised ICP, and ongoing fever. up to 80% of them may have unilateral features. So they may come with hemiparesis or with motor aphasia. And MRI usually shows unilateral cortical swelling, as shown in this image as well. So there's unilateral cortical swelling, T2 hyperintensities involving one half of the brain, with or without leptomeningeal enhancement. So much so there's a proposal to call it flames, which expands to flare hyperintense lesions in MOG-associated encephalitis with seizures. So the highlight of this is that there is encephalopathy, altered sensorium, there are seizures, and there are flare hyperintensities, usually localized to one half of the brain. So this is the summary of the different phenotypes that we end up seeing. So it can be optic neuritis, transverse myelitis, ADEM, encephalitis, and it can be a complete NMOSD kind of a phenotype, which is seronegative for aquaporin 4. So these were the MOG diagnostic criteria which came out in 2018, but personally I find them quite vague, because the summary of this criteria is that if the patient is MOG positive with any type of demyelination, he's MOG positive, he's MOG associated disorder. So the criteria number 1 is positivity for MOG. Criteria 2 is the phenotype may be M, optic neuritis, transverse myelitis, brain syndrome, any combination. And once we have ruled out it is not aquaporin 4, it is more likely to be MOG. So this is something which will possibly undergo revision in next couple of years, and it should undergo revision because a lot depends on what criteria we are following when we are dealing with these kids, because otherwise it's a very open field as of now. The phenotype with respect to age, we saw multiple phenotypes, but if we try to summate them, in children who are less than about 9 years, they usually end up presenting with an ADEM kind of phenotype. And as these kids go into adolescent and become adults, it is more likely to be an optic neuritis and a transverse myelitis kind of a phenotype. So among the various phenotypes, the children are more likely to be ADEM and adults are more likely to be optic neuritis with or without transverse myelitis. But the relapse may not occur with the similar kind of phenotype. This is something which we are seeing in our consortium database as well, that the kid may start as ADEM, but subsequently relapse as optic neuritis. Optic neuritis may come back as ADEM. Optic neuritis may come back with the NMOSD phenotype. So if a child who has earlier had ADEM and later on comes back with a vision loss, the chances are he still has MOG positivity, and he's coming back with a MOG related demyelinating event. Now, MOG positivity and relapse, this is a area which is highly debated, and there's only one good paper which came out about 2 years back. So they looked at about 274 children, out of which just 62 were MOG positive. And if we look at the last line of this, neither the presence of MOG antibodies at onset nor the subsequent persistence were associated with relapsing disease. So what it means is that the idea of frequently repeating MOG titers every 3 months or 6 months doesn't help us in predicting whether the kid is going to relapse or not. So those who have persistence of MOG antibodies are as likely to relapse as those who have turned MOG negative after the treatment. So frequent checking of MOG antibodies as of now is not recommended. Treatment, the acute attacks are managed just like any other demyelination with parenteral steroids. If the child is sick, then we add IVIG also. And frequently in cases of myelitis, usually going in for plasma exchange also earlier on. Hypothetically, it makes sense, though we do not have any studies to support one over the other. But the traditional treatment is give methylprednisolone. And if there's one takeaway from this complete lecture is, then methylprednisolone should be given in a complete dose, which is 30 mg per kg per day for 5 days with a maximum dose of 1000 mg. A lot of times we end up getting patients who are treated half-heartedly with 10 mg per kg per day for 3 days, 2 days, So that kind of a treatment doesn't make sense. Attack prevention, again, this is a completely gray area. We do not know much about it, but as of now, the suggestions for most of the papers is that majority of these patients have a monophasic course. So immune suppression should be reserved for those who relapse. Though there is a strong voice against it already, because there are a lot of papers which are showing that even with the monophasic course, if they end up relapsing, then they start accumulating some amount of disease. So EDSS starts dropping with every future relapse. So a safe or relatively safe immune suppression may work for them. But again, the jury on this aspect is also out. We don't know the exact answer. The options available for prevention include azathioprine, mycophenolate, monthly IVIGs, oral prednisolone, rituximab, and there are now reports of using tocilizumab also for treatment of MOG future relapses. Now, this was a very interesting paper which included both adults and pediatric cases, and what they showed was that oral prednisolone was most effective. The numbers are small, but they showed that prednisolone, a long paper. So they gave prednisolone. They included kids and adults who received prednisolone for more than 6 months. And they showed that those who had a long taper over 6 to 12 months, 95% of them did not relapse. With rituximab, again, the numbers are very small, but majority of them did not relapse, and they fared much better than IVIG and mycophenolate. This was an exclusive pediatric study, and what they showed was they did not have steroid cohort in this, but they showed that rituximab and IVIG tend to do better than mycophenolate and azathioprine. And the MS-related drugs, they have got no role in the management of MOG. So the main takeaway from these 2 or 3 slides is that a kid or an individual with MOG positive demyelination is more likely to relapse if he or she has an NMO spectrum disorder phenotype. And if the kid has received immunotherapy other than rituximab, IVIG, or steroids. Now, we've looked at this extensively in our data as well, and we're still working on it. But the initial results are in sync with this, that if the patient has received initially a long taper of steroids, or has received rituximab, or has received IVIG over 6 months, the chances of relapse and the chances of accumulating deficits is less than if he has been treated with azathioprine mycophenolate. Again, multiple studies have shown that multiple sclerosis related treatments have got no stay as far as MOG disorder is concerned. So to summarize the treatment, the acute episodes to be treated with steroids, IVIG and plasma exchange may be added depending on the severity of the disease, and maintenance, if you have to go for one, then it has, we would prefer rituximab because of long-term steroids may be associated with different kind of other problems. But if finances are an issue, then steroids are a relatively cheaper option. And the treatment of multiple sclerosis has got no stay as far as the treatment of MOG is concerned. I'll end with couple of things which I found very interesting. Now, this is there are now numerous reports related to this, that the patient presents with clinical findings, clinical features of encephalitis or myelitis. MRI is normal, but MOG is positive. So imaging negative myelitis, imaging negative encephalitis, but turning out to be MOG positive. So honestly, we don't know how to deal with this. At least I don't know how to deal with this. We currently also have a kid who was MOG positive earlier, completely recovered from it, was asymptomatic for 2 years, came back with status, admitted elsewhere, came back to us after resolution of status. MRI is normal, but MOG is positive. So again, we don't know how to deal with this condition, this kind of a scenario, and this is something pretty exciting, that there are attempts to develop MS vaccine using MOG-based epitopes. So maybe in next 5 or 10 years are going to be pretty exciting with regard to this entity. So I'll conclude with this, that it should be considered differential for all acute demyelinating syndromes. Because if you find MOG positivity, the chances are it is less likely to be turning to MS and less likely. And based on the imaging characteristics, one can make out whether it's MOG or NMO or MS. And if it is not MS, then MS-based therapies should not be instituted because they usually do not work in MOG. I finished, sir. Any questions? Yes.
Sir, Udani sir.
Oh, sorry, I was mute. Thank you very much for your excellent presentation, Vishal. We'll start off directly with the question answer session because there are lots of questions, and I just so first question is from Dr. Agarwal. Minan, you could take this. Is there any difference between para-infectious and post-infectious in the background of acquired demyelinating lesions, or are they synonyms?
I think you see that is yeah, it's almost synonymous because they changed that post-infectious was the initial term, then they changed it to para-infectious because it's very difficult to say that when the infection was stopped and when this demyelination started. So that is one thing. And then when the term of ADEM came, they completely omitted the term of that infection and demyelination in that because it's very difficult because there are some ADEM studies, pathological studies, which says that there are active viral inclusions in these lesions. So there is a demyelination going on in one side, and there is an infection also going on one side. So it is primarily the final endpoint is an infection triggered some kind of an immunological response, and then the virus contribution of that is how much is not very clear. So it is very, very non-committal at this point. It is an acute disseminated encephalomyelitis, which doesn't say that there is an infection, and even without infection, with infection, the overall approach is the same.
Okay, great. This is from Dr. Kalani. He's asked a bunch of questions. The first is about the incidence of false positive MOG. I think you had a slide on that about healthy controls and false positive, and you mentioned sometimes you get an atypical condition like glioblastoma, etc., and NMDAR, etc. So how do you interpret this, and how common is this?
MOG false positivity actually, what is happening is it has been a question. It has been debated over the past decade or so. Again, as I said, is it a innocent bystander, which we are trying to use as a biomarker, or is it actually pathogenic? So false positivity is there. So any disease which is causing, let's say, a myelin damage, any injury to myelin will expose the MOG as an antigen and will lead to formation of MOG antibodies. So that's why it's occurring in glioblastoma in some patients with NMDAR. But if NMDAR positivity occurs with MOG, it is usually treated as an anti-NMDA encephalitis rather than as MOG. So initial treatment stays more or less the same. But implications in interpretation of MOG positivity stays that the MRI features and the clinical features are matching with demyelination. Then we call it as a MOG-associated demyelinating disorder.
Okay, but do you have any? Sorry, go on.
No, I was taking the next one as well. That what is the endpoint of treatment in MOG? So we do not chase the MOG antibody titers. It is the clinical resolution of the resolution of the clinical syndrome what the child came with is usually taken as the endpoint. We do not keep on chasing the antibody titers over here.
Okay, but what is your overall? Talk on titers, for example, when you said false positives, would the titers help in this? If you have very high titers of MOG, would that tell you it's less likely to be false positive?
So if anything above more than 100, in fact, 1:200, anything more than 100, it is less likely to be false positive.
Okay. Dr. Kinney has asked about clinical symptoms of MS in children. Is it different from adults, KP? And
Hey, it is,
that,
yeah, the clinical symptoms almost the same, because it is primarily we are looking at the MRI. You will see it's a clinical radiological syndrome, so without a biomarker. So when we are looking at that presentation, there is a what you call a gradation, where we can have a little more seizures. See, anything comes in, children will have more seizures, encephalopathy to some extent. So that is one thing which is it is not specific to MS, I'll say. But what is striking is this the type of lesions. There are some earlier studies which says that there are large confluent lesions and all in childhood MS. But I am a little skeptical at this point, because most of the earlier studies have to be relooked with this MOG into the picture. So many of this, the so-called MS, which we called later in earlier in children, may be actually MOG antibody disease. So we may need more studies now with the current criteria to clearly say that the children behave differently from the adult population with the strict criteria of MS.
Do you think any case presenting with so-called MS, because it's much less, especially in the very young age group below 12, you would consider always doing a MOG antibody and etc. in those cases before labeling it as MS, or you would? Because that's not part of the
definitely. See, now the current McDonald's criteria, which they say is in populations where the prevalence of MS is low. That includes, see, in India, we have two things. One is the geographic distribution per se, considered as this region is not so prevalent with MS. Then the other thing is we are dealing with children. So these two things, two populations are actually having a low prevalence of MS. So in such situations, you have to do all the other investigations, and especially MOG, because MOG is one thing which presents with recurrent demyelination, which is a cause of recurrent demyelination, which can have multiple presentation, as Vishal has already told. So in such cases, MOG antibody testing is a must before branding, because the standard MS treatments may not help there. I may have to go to the second generation MS treatment according to the MS literature, or the standard anti-MOG treatment according to the MOG literature first itself. So in such a case, it is always better to do MOG at this point.
Okay, thank you. There's an interesting question from Sridhar Joshi. How do we explain cortical lesions in MS and MOGAD? Is the antigen present in the cortex, or is it transsynaptic degeneration? That's a tough one, but I'll leave it to Vishal to answer.
So the antigen is actually present in the myelin sheath. So it is not exactly in the cortex, it is in the subcortical white matter where the antigen gets exposed. And it's a complement-mediated degeneration, or the complement-mediated damage which takes place over there. Now, how the complement crosses and how the antibody crosses the blood-brain barrier and reaches the myelin over there is still a matter of debate. So I personally tried to look it up over the past 2 days, and I have not been able to find out the exact answer. How do the antibodies reach that particular antigen site? Because most of the studies have shown there's hardly any intrathecal production which takes place for MOG. So it is more of the peripheral production which crosses the blood-brain barrier and reaches the site. So honestly, we don't know, but the antigen definitely is MOG, which is a transmembrane protein in the myelin. How do the antibodies reach there? That is the bigger debate.
No, but the question here is why the cortex?
How does the cortex get involved?
So it's the inflammatory edema which takes place. So it is so the umbra zone is the juxtacortical area where the myelin is present, and the penumbra zone keeps on involving the associated areas.
Okay, yeah, so I think that's we all agree that there's no antigen in the cortex as such. It's just that
because it's a myelin-based antigen.
No, as far as the MS is concerned, I think it is the pathophysiology is not very clear at this point. We have the black holes. There is a degenerative component in MS. It's not only the inflammatory thing. See, the pathophysiology is not completely clear at this point. So what we are looking at is that this criteria changes, because they look at the existing criteria and the current the newer literature which is coming up, which says that there is no difference between cortical lesions and subcortical, or the so-called juxtacortical lesions. And then they try to, so some of this criteria comes not based on the pathophysiology or the excitative to putative pathophysiological mechanism. It is based on the patterns which is seen in the MRI. So this cortical thing, I feel like the new criteria, McDonald criteria, they included cortical because of the newer literature which says that there are actually cortical lesions in MS, which is maybe a kind of inflammatory reaction, or it is some other what you call cell-mediated immunity or some other thing, which is not very clear. The pathophysiology is not very clear at this point.
Yeah. I just give a short answer to this question. Differences between recurrent and multiphasic ADM. Is the term recurrent basically not recommended at this present time?
Yeah, but it's just it complicates the picture. So they just took it out after the 2012 modification. They just took it out and then said that it is same. You don't have to differentiate between recurrent and multiphasic. You just say it is a multiphasic AD.
Why do you get fever in Mogad, Vishal?
It's a central hypercytokinemia. He has himself answered the question. So it's the cytokine storm which is causing it. It is not the central kind of a fever because of thalamic hypothalamic involvement. No. So it's a peripheral antibody which is mounted as in the native immune system, which leads to fever, and the brain manifestations come along with that.
Okay, because there's a lot of systemic inflammation even in this ESR and CRP and all that. So,
yes.
Anyway, now we go a little bit onto the treatment. There's a lot of questions on treatment. One is this an important thing to tell us about what is your personal policy on treating MS? I mean, if you see MS, you sort of if you're sure it's MS, you start disease modifying therapy straight away. And what is your personal choice? Do you use fingolimod in second line, but do you use DMF or do you use injectables, or what do you do?
Sir, I have to confess here that my call of MS is actually very, very limited, because I tend to call very less something as MS because of our worry, because of something which we usually are not used to. But the current trend in the MS literature is there are two kinds of MS treatment options. One is going for the step-up approach. That is, you start with the interferons and then go up and then see whether it is working, and some of them may stabilize with that. And then if you are not stabilizing, or they have got a significant hypersensitivity reaction, they go to the second generation, which is what we call the oral drugs, the fingolimod, and or the standard infusibles like Rituximab. But my feeling is, since this MOGAD come into picture, and then the other things, the NMDA antibody, we use a lot more Rituximab. The only problem with Rituximab in adult practice is it is an off-label thing even now, but people are using it in a lot of settings in adult practice. And then there is a Swedish registry which says gives the importance of Rituximab, and then the pediatric guideline which I come up also suggests Rituximab. Only problem is there is no clear data, and then it's a cheap thing. So I think over the year, in the next few years, we will see more and more Rituximab. And then the good thing about that is we don't have to be worried about this MOG antibody positivity or the other thing. It is you can use it in both, because if it is a MOG antibody thing, and definitely the interferons are not going to work. That has been shown in many studies, and Vishal has shown that. So that way, in the MS literature also, there is a lot of discussion whether we have to go for a step down approach. That means you start with Rituximab or the Ocrelizumab and go down to interferon after the disease stabilization. The only problem with that is this is a chronic immunosuppression, not like MOG or NMDA, where we expect that after some time there might be a patient going into remission after some time. and then you don't have to continue it for long. So there is it is not very clear at this point, but I prefer to use rituximab at this point rather than a standard MS drug because of the cost and other issues. That's the last sentence.
Yeah, I just ask I think we are running short of time because there are two more talks. So Vishal, there are lots of questions on the, use of steroids. How long do you use steroids in the initial part? When do you sort of give also IVIG? What about rituximab? How long is your course of steroids? In general, do you give a longer course or a short course in most cases? And about the rituximab as well, what is your
So our personal protocol is we give IV methylprednisolone 30 mg per kg per day for 5 days and start the patient on 2 mg per kg per day of oral prednisolone. If the child is sick with, let's say, paraparesis and bowel and bladder involvement, we straight away add IVIG. If the child is encephalopathic and the encephalopathy fails to improve, let's say on the 3rd or 4th day of steroid, we start IVIG. We add IVIG by about 3rd or 4th day of steroids. There are certain situations where the kids have come with ongoing fever and encephalopathy, and we are unsure whether we are dealing with infective encephalitis or MOG. So those are the situations where we have even started IVIG upfront, and by the time we get MOG results and we are sure that it is not an infective etiology, that is the time we have added methylprednisolone. So that is tailored depending on the individual patients. But as a thumb rule, IV steroids 30 mg per kg per day for 5 days, followed by oral prednisolone. We usually end up adding rituximab after about 3 to 4 weeks in illness. We give 2 doses upfront and we repeat a dose 6 months later, and that is the end of the treatment unless and until the kid comes back with a relapse. If the patient is not able to afford rituximab, that is the time we go for long-term steroids for about 6 months or so with a slow taper, 2 mg per kg per day for 4 weeks. Thereafter, 1 mg per kg per day for another 2 months. And after 3 months, we keep them at 0.5 mg per kg per day. It is a protocol which we have borrowed without any shame from nephrotic syndrome group. That is the way they end up treating nephrotic syndrome in pediatrics, and we have kind of borrowed it from them.
Okay, and rituximab, you basically there's some. Can you discuss on that a little more? Whatever you said.
We give 375 mg per meter square at day 1 and repeat 375 mg per meter square on day 14. So these are the 2 doses which form the baseline dose. And 6 months later, we just repeat 1 dose after testing for CD19. If the CD19 is less than 1%, we do not repeat it. If the CD19 has gone above 1%, that is the time we repeat it. Otherwise, we do not repeat it.
And you go on for a year, maybe?
We just give one baseline dose, induction dose, and 1 supplementary dose. Thereafter, only if the kid has any symptoms or relapses, then we go for the 3rd dose. Otherwise, no.
Okay, I think we'll stop over there. I know there are a couple more questions, but I think it's a bit late, so we'll go to the next one. Okay, thank you very much, KP and Vishal. I think it was a good session, very nice session.
Thank you.
And thank you for participating so actively. We go to the 3rd speaker. This is from Dr. Arushi Saini. She's a young and upcoming pediatric neurologist from PGI in Chandigarh, and has been, her main interests appear to be neuroimmunology, neurometabolic disorders, and movement disorders. And she's had a couple of awards, which are very prestigious international awards, and lots of publications in peer-reviewed. And basically, I think she's going to talk on NMDAR encephalitis with a focus on movement disorders, which are so much more common in the pediatric. Arushi.
Thank you, sir, for that kind introduction. And am I audible?
Yes.
Yes, ma'am. The International Parkinson and Movement Disorder Society, Asian and Oceanian section would like to thank you all for joining part 2 of
share my screen, right? So 1 second.
Yeah, just share your screen, yeah.
Yeah. Good morning, everyone. And is my screen visible, sir?
Yes, ma'am.
Okay, thank you. At the outset, I would like to thank IAN and AOCN for this opportunity, and I'll quickly come to the topic which has been assigned to me. We are going to discuss movement disorder in autoimmune encephalitis, and we are going to discuss primarily about the NMDA receptor, anti-NMDA receptor encephalitis. Now, just to brush up ourselves, if we have to think of a pediatric autoimmune disorder where movement disorder is the defining feature, let's see what comes to our mind first. So I suppose typically we will have Sydenham's chorea, where chorea is the defining feature, or we have OMAS, where opsoclonus or myoclonus is the defining feature. Now similarly, if we have to think of a pediatric autoimmune encephalitis where the movement disorder is very prominent, undoubtedly the anti-NMDA receptor encephalitis comes to our mind. The second important group which is upcoming is the autoimmune basal ganglia encephalitis, which is being described with dopamine type 2 receptors which are in the basal ganglia. So for today's talk, we are going to focus only on the anti-NMDA receptor encephalitis and the associated movement disorder. Now, in the current era of genetics and panels, one might ask that what is the need to discuss the clinical phenomenology, but we have to remember that the clinical part is very, very important, because this helps in very early identification, even in the acute stage, even before your lab tests are available, or even before the characteristic or a complete clinical syndrome has evolved. So identifying the clinical phenomenology in any movement disorder is the crux of understanding as well as identifying that disorder. So just a bit about NMDA receptor encephalitis. I suppose all of us know that this is a diffuse, multiphasic, multi-stage disease. So the early features in children are usually prodromal symptoms. The common trigger is fever or a viral illness. However, in 50% of the cases, we may not have a trigger. This is rapidly followed by a lot of behavioral and cognitive changes with neuropsychiatric symptoms and language, and movement and features like recurrent seizures and movement disorders usually come in the second stage, or let's say the second and third weeks. However, increasingly we are encountering presentations where seizures are the presenting manifestations, or movement disorders are actually the presenting manifestation of the NMDA receptor encephalitis. So again, there's a spectrum to it, and we just need to identify the key clinical features. So just as the phases progress, the recovery often occurs in the reverse order. And for today's presentation, we'll just focus on the movement disorder in the anti-NMDA receptor encephalitis. We'll try to see what is common in that and what is not. What is the phenomenology, and how can we dissect out the complex syndrome or the complex cluster of movement that happens here into a simple phenomenology. And we'll just discuss a couple of cases on the way. We'll not be discussing the acute and chronic treatment aspects because they are a separate topic in itself. So I'll begin with this case discussion. This was a 4.5-year girl, rather the first case of anti-NMDA receptor encephalitis that we saw at our center. She had presented to us almost after 2 months of her illness. There was complaint of persistent abnormal involuntary movement and a persistently impaired awareness. The illness had started with a brief episode of fever. Subsequently, parents started noticing that she had become aggressive. She had irrelevant talking, was irritable, stopped recognizing the parents. Soon, a lot of involuntary movements came in. There was associated sleep disturbance by the second week. There was progressive speech and cognitive impairment, and then she also started having intermittent generalized tonic seizures. Now, as she progressed into the second month of her illness, she became completely unaware, mute, and had insomnia. The involuntary movements persisted, and there were intermittent seizures occurring. She was initially admitted, treated at a local hospital. Her neuroimaging was normal. I'm sorry. Her CSF had shown mild lymphocytic pleocytosis, so she was given a presumptive diagnosis of TBM and started on ATT. She was also started on anti-epileptic drugs, and as a complication to which she developed Stevens-Johnson syndrome. So finally, after 2 months of these persisting, evolving, and worsening symptoms, she came to us. There was no significant history of any illness which could suggest a metabolic disorder or a toxin ingestion. So on the examination, when she presented to us, there was complete lack of awareness to self and environment. There was no sleep-wake cycle. There was no meaningful response to visual, auditory, or tactile stimulation. She was not following or fixating. Because of the chronic illness, she had become malnourished. There was variable tone, and her fundus examination was normal. Now, what was characteristic was these continuous involuntary movements. Now, what is obvious in this cluster of movements is she's having some movements which are continuously repeating, and there are a lot of movements which are localized to the head, the neck area, and the face. And then there are a lot of movements which are kind of chorioethetoid movements which are occurring in the limbs. So at least in this cluster of movement, what we can say that she probably has a hyperkinetic movement disorder. But in addition, she had a lot of oral grimacing, eye blinking, persisting blepharospasm, a lot of tongue thrusting, stereotypic no-no type of head movements, and some chorioethetoid movements of all the four limbs. So as I said earlier, movement disorders in children sometimes are a clue to an underlying diagnosis. So in this particular case, because of the long duration of illness and this typical cluster of movement disorder, immune-mediated encephalitis was considered upfront, and subsequently the diagnosis of anti-NMDR receptor encephalitis was also proven. So what is the importance? This is an important part of recognition of encephalitis and is often the clue, as it was in this case. The movement disorder in NMDRE are often dramatic. They could be mistaken for seizures, and these children could be on a lot of anti-epileptics before the movement disorder part is dissected out. They are very common, often the presenting feature in children. They are generally hyperkinetic. They are generally generalized as opposed to adults, where you may find a lot of focal manifestations. They are mostly seen in the second stage, but up to 1/3 of cases may also have the movement disorder right at the presentation. And these are generally associated with sensorial changes, although 1 to 5% of cases can also have an isolated movement disorder presentation, although the illness tends to evolve later on and other symptoms come in tandem. So this is another case. So after the first case, this was another girl which we saw and we published. So again, if you look at the video, you could say that there is a mixed movement disorder syndrome occurring. What you can observe is there are a lot of stereotypic movements which are complex bilateral anti-gravity movements. There are a lot of pin rolling movements. The movements in the hands take your attention. But also try and focus at the eyes. There is almost opsoclonus-like movement occurring. There are a lot of eyelid spasms occurring, a lot of movements in the oral area as well. So you can see there is a movement predilection for the face, for the head and the upper limbs. So there's something occurring on the dyskinesia spectrum, a lot of stereotypies, and there is probably a status dissociatus. Now, what is that? So an important part to recognize is that in the background of all these movement disorders, we can see that the child has near continuous motor behavior, but there is absence of a polysomnographically defined conventional REM or NREM sleep stages. So basically what happens in NMDA receptor encephalitis, we have 3 distinct stages of states of awareness, which are wakefulness, REM sleep and REM sleep. So when their boundaries are blurred, the child or the patient remains constantly in a state of agitated wakefulness, and which is associated with a lot of movements. Now these are commonly seen after sleep deprivation or brainstem lesions or thalamic lesions. However, in NMDA receptor encephalitis also, the movement disorder is associated with a background conscious child, but who has a reduced or a paradoxical responsiveness, which alternates between agitated wakefulness as well as catatonia. So this has also been referred to as a light switch mental status. So the key feature here is a movement disorder with the background of a status dissociatus or a light switch mental status. Now just a word about why these movement disorders are occurring. We do know that the antibodies decrease the receptors on the surface. There is a lot of internalization of these receptors, because of which there is loss of NMDA receptor mediated currents. So basically at the synapse level, what happens is that there is excessive glutamate and reduced GABA inhibition. So this affects the frontostriatal pathway. There is loss of frontostriatal inhibition. This results in psychosis, catatonia, mutism, also contributes to rigidity and dystonia and repetitive movements. Now it is understandable that the basal ganglia is the house of NMDA receptors, so it is understandable that the movement disorder is probably coming for there. But what is important is that this encephalitis also removes the cortical limbic control of the brainstem and the hypothalamus. Now these are the centers for the generation of semi-rhythmic movements in the body, and hence because of this loss of inhibition, a lot of semi-rhythmic movements also come, including stereotypies and perseveration. So what could be the different type of movement disorders? We have seen this cluster of movement disorders, but if you look carefully, there are certain specific subtypes that you can identify here. So different studies have given number 1, 2, 3 type of most common movement disorder. But essentially, if you try and understand, in the younger age group, there is a lot of hyperkinetic movement. In the adolescent and older patients, there is a lot of catatonia and hypokinetic movements, generally as a rule. So some of the studies have seen that the orofacial lingual dyskinesias, the chorea and the dystonia, I'll treat here as a spectrum of hyperkinetic abnormal tone movement disorder. So this is more common than the stereotypies and the perseverations. However, other pediatric studies have found that dystonia and stereotypies are almost occurring together, and stereotypies occur with perseveration as an associated movement disorder. Now, in our experience also, when we looked at our cohort of children with NMDA receptor encephalitis, the dominant presenting features were, of course, the neuropsychiatric and the manifestations and the movement disorder. But among the movement disorder, we also found that the predominant one would be the orofacial dyskinesias, the choreas and the dystonia. I'll put them together so that we understand the spectrum. And the second most common group is of stereotypies, which could be complex or simple. So now, is the movement disorder discriminating, or it is just a jargon of different terms? So it has been studied that stereotypies and the perseverations are actually very specific for anti-NMDA receptor encephalitis. So if you are suspecting an autoimmune encephalitis, and if you have a lot of stereotypic, which are patterned movements with or without motor perseveration, which is sustained movements, so in that case, it probably indicates toward NMDA receptor encephalitis. Taking the other case of the basal ganglia encephalitis, if there is a lot of hypokinesia or akinesia and bradykinesia, then it is probably a basal ganglia encephalitis. Now, these repetitive orofacial movements have been put under orofacial dyskinesias as well as motor stereotypies. However, there is slight difference. The dystonia movements have to be dissected out from the repetitive, otherwise stereotypic pattern movements. The chorea and the dystonia are least discriminating from an autoimmune encephalitis point of view. So, what is important in identifying that the stereotyped motor phenomena is the key, and this probably is a clue to an autoimmune encephalitis. Now, there are, as I said, a lot of phenomenology being used. I think the best approach in dissecting out this cluster of movement disorder is, whenever you see a child or a video of a child who has this lot of movement disorder, try to identify 1 or 2 dominant movement disorder and then identify the rest of the associated movement disorders. So there can be 1 or 2 more dominant features, and there will be less dominant movement disorders or different phases. So child may have, at different times of the day, may have different type of movement disorders. Now, as I said earlier, to remember, the first group can be the dyskinesia spectrum. Now, the term dyskinesia is less often used for describing NMDA receptor encephalitis because this is kind of a non-specific term. But for understanding here, let us put the dystonia, the choreoathetosis, the orofacial lingual dystonia, dyskinesias, and the chorea and the athetosis, which are less commonly seen because they are together. Usually, they occur in combination. So let us put them together as the first most common group of movement disorder, and let us see them as a spectrum. The second group would come as a stereotypy and perseveration, and the other type of movement disorders are actually very less commonly seen. So if there is a paucity of movement disorder, this is usually not commonly seen in anti-NMDA receptor encephalitis. Similarly, myoclonus, bellismus, tremors, ataxia are very uncommonly seen. But yes, at the onset you may sometimes see, but they rapidly tend to evolve into other movement disorders as well. So from now, we'll see some case examples. Now, the orofacial lingual dyskinesias, the term is self-explanatory. What are the examples of such movements? So you will see a lot of sustained and repetitive sucking movements, rabbit mouth movements, clicking, rolling, protrusion of the tongue, grimacing, jaw opening and closing. So this is a typical rabbit mouth movement. This is not a patient with anti-NMDA receptor encephalitis, but this is just to show you what the rabbit mouth movement looks like. Now, this has been seen in children with anti-NMDA receptor encephalitis also. So, each of the video will have additional movement disorders, but right now I want you to focus on the dyskinesia part of which is here. And similarly, so even if the child is encephalopathic, is not moving much, if there is not much of other movement disorder, you can focus on the oral, facial and the lingual muscles, and that is how this is the most common and the most defining feature. Now, so these can sometimes be associated with acral dyskinesias as well, but typically they are seen with blepharospasm and lingual. So if you're suspecting autoimmune encephalitis, I suppose the first area to focus is look at the face, the tongue, the head region, and look at what kind of dyskinesias you have here. This is again the previous case, but if you look at the face, there is very rapid, quite hyperkinetic movement, and the eyes are almost moving in an opsoclonus-like fashion. So this is the key feature that we need to identify. Moving on the spectrum, sometimes children can have frank dystonic posturing. So there are other movements as well, but you have to look at the dystonic posturing. It is sometimes can be intermittent, sometimes it can be very severe, and there are reports of NMDA receptor encephalitis almost mimicking a glutaric aciduria type like crisis presentation. So just keep in mind that you may see a lot of things on the spectrum as well. Now coming to the second group, which was stereotypy and perseveration. Now stereotypies, we know that these are involuntary pattern repetitive movements which are rhythmic, but they are purposeless. They are typically distractible. However, that may not hold true in a child who has altered sensorium such as anti-NMDA receptor encephalitis. They are usually classified as simple and complex. Simple means simple cycling of legs or thrashing movements of one limb, or the head, no movements of the head. The complex ones are more common in autoimmune encephalitis, where you may have simple raising and lowering of the arm, or you may have frank thrashing movements of the arms, limbs, pelvis, etc. Sometimes there can be fine finger movements like playing piano, which we saw in the previous video as well. So this is an anthology which I have taken from a published case. Let us look at the typical stereotypic movement. So you see in this left hand and the left arm, this is the rapid complex stereotypic movement. Now it is also extending to the lower limbs as well. A lot of thrashing movements. So you can see in the limb. Now this is an example of oral stereotypic movements, but also focus on the eyes because there is intermittent oculogyric crisis, which is a part of dystonia. So you see this tongue protrusion, lip smacking kind of movement, and there is associated intermittent oculogyric crisis. This was our case again. I want to show stereotypy here, but look at the overall picture and try and identify two dominant movement disorders here. So if you look closely, what you find is that there is generalized fidgetiness, which shows a chorioathetoid type of movement in the child, which is constantly occurring. He had a peculiar stereotypy where he had this repetitive nose picking behavior. So again, as I said, I identify the two most dominant things which are occurring. So in this case, we had these dance-like or chorioathetoid movements with slight jerky quality, and the second was this repeated nose-picking behavior, which was appearing as a complex stereotypy. Now sometimes they can also have bizarre stereotypic behavior at the presentation. So this child had this shuffling gait, and later on she evolved to have a frank epilepsia partialis continua. This boy who was in acute encephalopathy had this hair picking stereotypy, and he constantly was doing it, but associated, you can also see there is a dystonic posturing in the other lip. Young children generally are very irritable, so a lot of with the stereotypies they will also be very irritable, crying, and it is difficult to ascertain whether dystonia is occurring together with it or not. But this thrashing complex motor stereotypies are generally a clue even in younger infants. This is again in an older child. You see a lot of vocalization also besides this complex stereotypic behavior. So you see the kind of vocalization he is doing, the kind of violent movements he is doing. So these are the type of complex stereotypies which are very characteristic of autoimmune encephalitis here. Now coming to perseveration, these are basically repetitive persistence of motor or vocal tasks. They are generally triggered by a stimulus. So for example, when you have an encephalopathic child, you try to move a limb and the limb goes into a persistent tonic posturing or goes into a clonic posturing, then probably what you are dealing with perseveration. However, it is usually seen as an associated movement disorder. It is hardly a dominant movement disorder. So we'll just see some examples. So in this child, when the limb was moving, you can see that one of the limb has gone into a persistent tonic posturing. The other one the child is trying to move. However, this side has gone into a persistent tonic posturing. Even when the stimulus was removed, she continued to remain in that state. And when there is persistent tonic stiffening, these can be confused with catatonic states. Again, going to this published case, a tonic perseveration, where you can see this flexed upper limb is after a stimulus is given, is constantly in this posture. I'll just show this video again because it's very small. So this is the tonic perseveration seen in this child as an associated movement disorder. Again, this video which we have seen previously, we saw the complex motor stereotypy, which was very bizarre, and here we see this persistent tonic posturing of the both upper limbs, which is a part of tonic perseveration, and associated you can always identify there is a tremulous movement along with the stereotypic head nodding. So as I said, each video, each patient will have a cluster of movement disorder. We just have to try and identify and dissect out the specific things from there. Now this patient has a very violent, bizarre thrashing movements, and has a combination of stereotypy as well as perseveration. So he had this repetitive movements, and then intermittently he had periods of catatonia, or you could say tonic perseveration. So after moving from the most common group and the second common group, let us see some examples of chorea, ethetosis and ataxia, which are less commonly the sole manifestation. So we have seen in the video that they are seen associated. Here we will talk about certain cases where they are the dominant solo manifestation. So we had seen this girl who had initially come with just mild hyperactivity and emotional lability. So there is no abnormality in her gait here. She's just walking by her usual self, and she was a happy child, but the parents had noticed that she had started crying. And within 2 weeks, she started having this chorioethetosis kind of movement, and her initial diagnosis, which we had thought of, was Sydenham's chorea. She eventually, after investigations, turned out to be an NMDA receptor encephalitis. This is Udani sir's case. I found this very interesting case. So sir has also described brief ataxia at the onset, which is also an uncommon solo manifestation of NMDA receptor encephalitis, but it does occur. And in the feet, you can see these chorioethetoid movements and probably some myoclonus. And again, this is the chorea and scanning speech at the onset. And you see, when he's asked to walk tandem, he has these worsening of chorea and large amplitude flailing movements. So after those examples, let us see the less common presentations, which are bradykinesia and rigidity. So sometimes when there is a lot of, there's a severe presentation and a lot of autonomic instability, these children may progress on to have bradykinesia as well. So this girl was initially for a couple of months was evaluated for changing affect and was being treated for depression. Gradually she slipped into this bradykinesia rigidity kind of spectrum, and she started developing myoclonus, and she was admitted for evaluation of SSP. You can see there is a lot of bradykinesia. The rigidity is not visible here, and there was intermittent myoclonus. However, she turned out to be affected with NMT and MDR receptor encephalitis and not SSP. And this is the marked recovery with immunotherapy. You can see the same girl, and this is how all of the functions return within a couple of months. So again, the presentation in children can be variable and bizarre. This is just another highlight, another case which I've picked up from the published cases. This girl here at presentation has unilateral chorioethetoid movements. So you see on the right side, there is intermittent distal chorioethetosis with intermittent tonic posturing of the upper limb and in the lower limb as well. Whereas in this case, this boy has the stereotypic abdominal myoclonus. So he is not encephalopathic, but he has this persisting abdominal myoclonus going on for several months, and he's right now undergoing an EEG to exclude an epileptic phenomena. This is another interesting gyratory events at presentation known in an adolescent girl. This has been described in literature, where she had this left-sided versive rotatory movements, and soon after, within the next week, she showed the typical presentation, where she became mute, had insomnia, and had these subtle orofacial lingual dyskinesias and acral dyskinesias. But this typical gyratory events were the presentation in this adolescent girl. Now, another movement which has been described is myarrhythmia. This is nothing but a type of a slow resting tremor. It is a very slow rhythm, let's say 1 to 3 hertz. It is not a typical rhythmic oscillatory movement, but it has an irregular frequency. It is not patterned like a stereotypy, but it is commonly seen in the distal limbs, and it is usually seen as an alternating flexion extension. So in this described case, you can see this is an encephalopathic girl, but she has in this right lower limb this slow myarrhythmia. So you can see an alternating pattern of contraction, flexion and extension, but it is a very slow rhythm. And this was another peculiar case where the myarrhythmia was identified in the left ear. So if you look at the left ear, you can see there is this movement. It's slower than a twitch, but this movement in the ear associated with a twitch here in the nasolabial fold. So this kind of atypical myarrhythmia is also sometimes described. So we'll not be discussing the principles of treatment, but if you have to treat the movement disorder, you have to treat the underlying illness, which is immunotherapy, several first and second line and third line, and of course removal of the trigger in children since the tumors are uncommon. So tumor removal is generally not of concern here. So with that, I'll just sum up the key messages here. So anti-NMDA receptor encephalitis is undoubtedly the most common, and movement disorders are the foremost clues in children. So identifying the phenomenology is very important. Remember, these are generally hyperkinetic, although as they go into adolescence, the movements tend to become hypokinetic. They are generally generalized movement disorders. In exceptional cases, you will see focal presentations. The movements are generally mixed or complex and sometimes bizarre. So what you actually see at first is just a cluster of movement disorders, and then it is on to us to dissect out the movement disorders as we discussed. The repetitive phenomena is the underlying theme of these movement disorders. If you have to talk about the characteristic movements of anti-NMDA receptor encephalitis, then these would be the orofacial dyskinesias and the complex motor stereotypies. And stereotypies and perseveration would be the most characteristic, which actually help them differentiating in the other from other encephalitis. Now, the encephalitis is very important because, of course, it is eminently treatable. But how would you next time when you see a patient, what can you try and do, or how can you approach? So I would suggest that first identify the cluster of the movement disorder or the movement disorder syndrome, as I call it. Then try and look for the 1 or 2 most dominant movement disorders, and then look for the associated features. And then you try and look for the background features, which would give you a clue towards the autoimmune encephalitis. The status dissociatus or these light switch mentation is a very important clue besides the movement disorder in children with autoimmune encephalitis. So coming back to the first case, this was her initial presentation. This was somewhere in between her partial response, where she still had a lot of her stereotypic behavior had reduced, but she had this perseveration and some intermittent stereotypies, but she was again in this state of irritable awakefulness, and this is near complete recovery after 1.5 years of therapy in her. So the message is the disorder is treatable. We have to identify it at the bedside and initiate treatment early. I thank my team back at PGI for the beautiful collection of cases, and of course our parents and patients, and I also thank IAN-AOCN for this opportunity. Thank you.
I think I've never seen a plethora of movement disorders as like a collage in the. I think we have an interesting discussion ahead. I think thank you very much for the superb videos and all that.
Thank you, sir.
Can I go on to the next case where we don't have much time now? Dr. Gauri Parsi. Gauri Parsi is a colleague and a dear friend. She's been, she's very much in the forefront of, if you go to any conference, you always see Gauri there. And she's the head department of pediatrics at Choitram in Indore, and has been done a DNB from the AIMS. And of course, a lot of positions held and publications as well. So basically, she's going to give us, her talk is basically on opsoclonus myoclonus ataxia syndrome, because of it's a very common problem in, not common, but it's a much more common problem in pediatrics, and very often can present in diverse ways, and I'm sure she's going to talk on all that. Gauri, please share your screen.
Hi, sir. shall I share my screen?
Yeah. If you have videos,
Yeah.
I would, when you open the Zoom, open the Zoom thing before you, on the left side of the share thing, it says,
Yeah.
optimize Zoom for video. Just put
I think I did that. I think I did that.
Let me share after that.
So. So can you see my screen, sir?
Yes, but there's too many screens. I think you put it on full screen. That's right. Okay, good.
This is fine. This is fine. Yeah.
Yeah, this is fine.
So thank you to IAN and AOCN for inviting me today. I'll be talking about opsomyoclonus ataxia syndrome. So it is said that if you see one patient with OMAS, you have seen one child with OMS. That means that each child is slightly different and behaves slightly different to the same therapy. You need to tweak your management. So this screen is not moving. Yeah.
No, it's moving. Yeah.
That's moving. So I begin with a case. This was a 2-year-old boy. He came with subacute onset ataxia for 1 month. The MRI was normal. He was given IV methylprednisolone for 5 days. This was in some other hospital. He improved. But after 7 days, the ataxia recurred. And this time he had extreme irritability. And the giveaway was the random eye movements which he had and the continuous brief myoclonic jerks. This was the child. Very characteristic. So we did a CSF. There were no cells, sugar was normal, viral panel normal, basic metabolic screen was normal, and we made a clinical diagnosis of opsoclonus myoclonus ataxia syndrome. So the diagnosis of opsoclonus myoclonus ataxia syndrome is largely clinical, and this recent international consortium, which published in March 2022, said if you have 3 of these 4 criteria, you can make the diagnosis. So he had opsoclonus, he had myoclonus ataxia, and significant behavioral disturbances. So that was our clinical diagnosis. I don't need to tell you all about opsoclonus, but I just want to show you a video of some of these children who have this extreme irritability, which we must pick up. The other strong handle for this disease is opsoclonus. So we must know how to pick up opsoclonus. So opsoclonus is precipitated by eye closure, by saccades, and by convergence. And you could do any of them. So if you ask them to close one eye, forcibly open it, you will see the opsoclonus. Is it simply a clinical diagnosis, or are there any good biomarkers? The short answer is no. There's a huge list of biomarkers which have been evaluated, of which one of the good markers was described by the Prantazeli group in USA in 2005 or so. They described that a small percentage of these children have B cell clonal expansion in the CSF. And that has been useful to predict response to Rituximab. Very simplistic pathophysiology of OMS, either the neuroblastoma or some viral infection induces a B cell and a T cell response, and that causes CNS injury. One of the predominant cells which are involved are the Purkinje cells. And the cerebellar control of the omnipause neurons in the pons result in the opsoclonus. Let me try to explain to you some of the hypotheses about how opsoclonus is induced. Now, the burst cell neurons in the PPRF control the saccades. And it is the omnipause neurons in the pons which control these burst cells. And the third nucleus which controls the omnipause neurons is the fastigial nucleus in the cerebellum. So there are two top contenders for the cause of opsoclonus. Some people, the first hypothesis is that the defect is in the omnipause neurons, and the second is that the defect is in the fastigial nucleus. But most of the data today, including functional MRI studies, it appears that the culprit is the fastigial nucleus. The primary defect is in the Purkinje cells in the cerebellum, and their control over the fastigial nucleus is gone, and that its control on the omnipause is gone, and so you have opsoclonus. The big question which many people have been trying to answer for a long time is OMS a B cell disease or a T cell disease? Because obviously it has implications for therapy. The evidence for B cell disease is that autoantibodies have been described in a small percentage of OMS, especially adults with tumors. They have been shown to have anti-RI, anti-HU, and anti-U antibodies. Second is the presence of clonal expansion of B cells in the CSF. And third is, of course, the good response to rituximab. However, the majority of patients have not been found to have autoantibodies. For years, people have been trying to find the autoantibody for OMS, and you have not found it. So does that mean that this is actually a T cell disease? People have also found that CD4 and CD4 ratios are low in OMS. And there's a very interesting case which is often quoted to give your weight to the hypothesis that it's a T cell disease, that it was a HIV patient who was started on antiretroviral therapy, and when he recovered, he developed OMS. So they feel it was a T cell mediated disease. The next question is, all of us know that neuroblastic tumors are seen in about 50% of OMS. But why are they seen only in 50%? For that, we need to go back to a study done in Japan. You know, neuroblastoma is very common in Japan. So they did a trial in 7 prefectures or districts of Japan. And they made 3 groups. One, they were controls. Second, they did qualitative screens. And third, they did quantitative screens. And they found when they screened for neuroblastic tumors, between 6 to 11 months, that is below 1 year, the quantitative screens, if you screened, you picked up patients, 17 children per 1 lakh population, whereas the controls were just 1. However, when they screened between 1 to 5 years, the pickup rate was non-significant, whether you did screening or it just came by itself. So the feeling is that neuroblastomas appear and many of them spontaneously regress. So the feeling is that in OMS also, there was a neuroblastoma. Sometimes it's picked up. Some of them have resolved, though they have induced the OMS and then resolved. So that is why sometimes you don't pick it up. The next question is, why are the neuroblastic tumors in OMS generally so benign? So there's a very good study from Italy in which they took all the neuroblastomas and they found that about 15 of them, 1.3% had associated OMS. And when they did the histopath of these patients with OMS versus the histopath of neuroblastomas without OMS, they found most of the patients with OMS had very significant lymphoid infiltration. So it appears that this lymphoid infiltration causes a very benign disease because the body is itself trying to solve its problem of neuroblastoma. But this immune reaction probably is the culprit for the autoimmune phenomena that we see. The next question which comes to mind is, are OMS patients with tumors different from those without tumors? So this is a very large study of 300 plus patients from the Prantazelic group. And they found there was no difference in age of detection, severity of OMS, the percentage of relapses, the response to any of the treatments. So the feeling is that patients with OMS do not differ from those without OMS. However, there's a small study from CMC Vellore, Dr. Maya Thomas and Dr. Sangeeta. They analyzed 22 patients with OMS, and they found that patients with tumors tended to present earlier, had more severe disease. However, their long-term outcomes were not different. That is our Indian data. What are the other associations with OMS? There's a long list of infections which have been associated with OMS. I just want to tell you about the new kid on the block. This month, there's been so much of excitement because of the NEJM article, which described checkpoint inhibitor therapy for colon cancer. And everybody is so excited that all the patients who got checkpoint inhibitor therapy completely recovered without surgery and without chemotherapy. So everybody thinks that checkpoint inhibitor therapy is the new miracle drug in oncology. But they have a problem, and their major side effect is autoimmune disease. So this year, the first patient with OMS secondary to checkpoint inhibitor therapy has been described. And the important thing about OMS with checkpoint inhibitor therapy is that they are highly resistant to the routine therapy. But there is a feeling that they may be treated with Natalizumab because it blocks the transfer of B cells from the blood to the CSF. What about post-COVID OMS? I did a very short survey of all the OMS reported after COVID, and there were 10 reports. Most of them were single reports, except 7 cases from Iran. The first case was reported from India, from Gujarat. And most of them were adults. There was one child who was just 4 months old. The majority were males. Most of them occurred in the first half of 2021, that is around the second wave of the COVID pandemic. And the duration between COVID and the onset of OMS ranged from 48 hours to 1 month. Most of them got IVIG with or without methylprednisolone, and nearly all of them recovered very well. So it appears that post-COVID OMS is a benign disease and recovers with short therapy. Next question is, how should we investigate? Agreed, it's a clinical diagnosis, but we must remember that 20% of the OMS are initially misdiagnosed. This is a beautiful study from UK. They found that 20% are misdiagnosed. So every acute onset ataxia in childhood, it would be a good idea for us to call them up after 2 weeks and look carefully for opsoclones. What are the recommendations for initial therapy? This is the recommendation by the International Consortium published this year. Of course, you do an MRI. In the CSF, it would be worth doing a glucose with a paired serum sample, because one of the close mimics of OMS is glucose transporter defect, and we must not miss that. It may be useful to do lymphocyte flow cytometry because, according to the Prantazeli group, B cell clonal expansion predicts good response to Rituximab. We have been doing urinary catecholamines, ultrasound, X-ray, MIBG scans, but they do not have very good sensitivities and specificity. Today, the gold standard would be to do a whole body neuroimaging from neck to pelvis, preferably an MRI over a CT with 4 millimeter cuts. So our patient, our whole body MRI was normal, urinary catecholamines was negative, started him on ACTH IVIG. After 2 months, there was still a partial response. So then was added, and over the next 2-3 months, his opsoclonus, myoclonus irritability resolved, but he still has.
They don't need.
So why do we treat OMS? We treat it because spontaneous resolution is rare. We treat it because there's a high rate of a chronic relapsing course. And we treat it because of the significant risk of permanent neurological sequelae. And what are the philosophies of treatment? Basically, there are 2 philosophies. The European philosophy is a little laid back, and the American is a little more aggressive. This is the protocol used by the multinational European trial of OMS, where they gave oral dexamethasone, 20 milligram per meter square per day for 3 days every month. They waited for 3 months. If there was no response, cyclophosphamide plus dexamethasone monthly for 4 to 6 months. No response, then rituximab. The North American approach is more upfront. And first, let us look at the evidence in favor of a more upfront approach. There are a few studies, but this study is a long-term follow-up study in which they found that patients who were diagnosed within 2 months of symptom onset had much lower neurological deficits and much higher full-scale IQs on follow-up. And that would tell us that probably we need to act fast in OMS. This was the first clinical trial in OMS published in 2018. This was an RCT. There were 2 groups. One group got cyclophosphamide, prednisolone, and IVIG, and the other got cyclophosphamide, prednisolone alone. And it was IVIG group was a clear winner. This is the upfront approach proposed from North America. The protocol is to start with methylprednisolone, 50 milligrams per kg per day for 3 to 5 days, followed by an oral taper over 3 to 4 months. If there's no response, they have not specified how long you need to wait, but it appears the way they described it in 2 to 4 weeks. There's no response. They start plasma exchange and IV with or without IVIG. No response, go to rituximab. Yes or no response, you need to go to rituximab. But if it responds very well to prednisolone, you quickly go to rituximab. And what they did was they compared the protocol group with historical controls. What were the advantages of the upfront approach? They found that the median steroid duration was significantly lower in the protocol group compared to historical controls. Cycles of IVIG required were lower. Percentage relapses were lower. However, the OMS severity score at 1 year was not significantly different. So the recommendation today is after your diagnosis, you must initiate treatment early within 2 weeks. You may use the upfront approach where you start steroids with IVIG, with without Plex, with rituximab or cyclophos, or you can do an escalating protocol. You start steroids, wait for 4 weeks, go on to rituximab, wait for 2 months, then switch. What is the evidence in favor of rituximab? These are 3 studies favoring rituximab. Patients who got rituximab versus those who did not get rituximab had less relapses. They had higher IQs, and the requirement for steroid and IVIG was less. The last option, which is recently been published, is only in 2 patients where autologous stem cell transplant was used for a patient with refractory opsoclonus myoclonus ataxia syndrome, who was refractory to IVIG, steroids, rituximab, cyclophosphamide, finally recovered very well with stem cell. Of course, you always need to know you're on the right track. So you need to monitor your response. And for that, you use the Mitchell and Pike OMS scale, which is available freely on the net. And there are 6 components, and which are scored 0, 1, 2. Stance, gait, opsoclonus arm function, mood, and speech. And you call it that the child is in remission if you get 0 score in stance, gait, opsoclonus, and arm function, though you may have 1 or less score with mood and speech. And which is true that most of the ataxia, the myoclonus, the opsoclonus goes away, but a little abnormality in speech and behavior continues. So to summarize, OMS, the diagnosis is largely clinical. The whole body MRI from neck to pelvis is the most useful test to rule out neuroblastoma. There are 2 approaches to management, either upfront or escalating, and early therapy definitely improves long-term outcome. This is one of my patients with OMS. Actually, it was Thank you. And this is my department and my hospital.
Thank you, Gauri. Excellent presentation. Lot of food for thought, actually. Now I take that thing to ask you first only. This story about from Japan seems very interesting. It goes away most of the, because we, in our own experience, we are about 28, 30 cases. Most of our cases, we basically use the DOTA-TATE scan.
Yeah.
When you're now, at least in the last few years, it's available in Bombay, the DOTA-TATE PET scans, PET-CT. We seem to be catching it almost in many patients where CT scans of the abdomen, etc., have been negative. What is your comment on that DOTA-TATE PET scan versus, because maybe those patients who have very small tumors, maybe they be picked up, as compared to MIBG, which is of course less.
So there are two things about it. One is most of these neuroblastomas, many of the neuroblastomas associated with OMS may be non-secretory. So, so they feel that we may not pick it up on these functional scans. Sometimes, some of them will be missed. Whereas structural imaging is more likely to pick it up if it's done very well with very fine cuts and an experienced pediatric neurologist. And the comparison of these of DOTA-TATE and MRI, I'm forgetting the study, but MRI scored better.
Let's start with the questions. First was from Dr. Ravi. He had an interesting question on how do you differentiate, this is for how to differentiate automatisms of seizures from stereotypies. And whether this is, for example, most speaking or whatever, it could be a seizure. Like we had a patient, I remember many years ago, an NMDAR encephalitis, which I thought was epilepsy partialis continua. It was just a repetitive thing like this, and she appeared to be partially aware. So it was confusing to good the video. What is your sort of take on that? How do you differentiate?
Sir, as you said, some cases would be really difficult, especially if there is encephalopathy, if the background alteration in sensorium is there. So in those cases, you may have to take the help of EEG. Again, what is the setting? If just like the case which I showed where the child is talking and doing other things and there is just intermittent this movement disorder, it may be little obvious that okay, this is probably a movement disorder and not a CPS. But if the child is encephalopathic and there is not much other clue, then we may have to, and we do have to sometimes look at the EEG and see whether this is an automatism or it's an epileptic myoclonus, or all those things can coexist. So EEG is utilized more for excluding sometimes. So in those cases, yes, you may have to take the help of.
Yeah, I think that's a message that you are in a bit of a quandary, you might go to the EEG. Now, the other thing, Gauri, is you have a patient, say, with a neuroblastoma. How do you sort of fashion your therapy? You want to give therapy as early as possible. So how do you give your therapy along with the surgery for the neuroblastoma?
True, that is a constant problem. So I didn't go into the therapy of neuroblastoma because that's under the purview of oncologists. But they have a risk stratified approach to the treatment of neuroblastoma with OMS. Your question, I understand that you have neuroblastoma, you need to take it out, but you also need to give immunotherapy. So the safest bet would be to start IVIG. Once you started him off, maybe you can give it over 5 days. By then the surgery is done, and the surgeon is okay for you to start on steroid after a week or so, and then you can start the immunosuppression after a week. And the neuroblastoma per se, the chemotherapy which is given depends on, today they risk stratified based on the genetics of the neuroblastoma, MYCN amplification, the deletions which are there. And generally, if you remember that Italian study, generally they don't need much chemotherapy. Most of my patients, we never gave chemotherapy, just took it out once and kept screening. But those, sorry, yes.
Go on.
So large proportion don't need chemotherapy long term. So we continue as OMS. We remove the tumor and OS as long as he's a low risk neuroblastoma. It is the high risk. Pardon? Yes.
Even if there's involvement of lymph nodes, because I've had this problem twice with my oncologist. The idea is lymph node was involved and he was insisting on chemotherapy.
So this international consensus has also got one subsection on how to treat the neuroblastoma, and they did not mention lymph node involvement. They said you go ahead based on the genetics. So you need to do the genetics and then decide whether he's going to need chemotherapy or not. That was what I understood, but I didn't concentrate on that part because it's part of the oncology too. But the rest of the immunotherapy we continue despite despite the chemotherapy going on, we continue immunotherapy. In fact, the reason why they discovered cyclophosphamide for OMS was a patient with neuroblastoma who had OMS was given cyclophosphamide and his OMS disappeared. So just removing the neuroblastoma never treats the OMS. So, but the first time they discovered the role of cyclophosphamide was because of the chemotherapy which was given. So, in part of the protocol of the OMS with neuroblastoma is cyclophosphamide has to be part of it. You probably prefer that over rituximab.
I'll just ask, I'm welcoming Dr. Tejul Taj from Malaysia, who's joining us and as a panelist. He's asked a couple of interesting questions. Tejul, why don't you yourself ask this question? Can you put your video on?
I think unless the digital team gives him access, he can't put it on.
Can he speak? Oh, he's on the... Oh.
He's coming with my name. That is...
Oh, it's your name.
He's there. He's there. Yeah, let him speak.
Yeah. Anyway.
Yeah. Unmute, Dr. Taj. No. No, but that's not. Yeah.
I'll ask on his behalf. The first question is to Arushi. In NMDR, those who present with chorea, they may look ataxic. And is that the reason why we have ataxia? Because she doesn't think it's a cerebellar ataxia, but it's just a sort of pseudo ataxia, so to speak. Is it possible?
It is possible, but not always. There are reports of isolated persisting ataxia, but yes, cerebellar ataxia is a very uncommon manifestation of NMDR encephalitis, sir. When I looked up, I found your case and one more case in an adult who had a 73-year-old patient who had clear cerebellar ataxia. So we can't say it is not common, but yes, this is a very important clinical point that we should rule out, that it's whether some other movement disorder is interfering with the posture and balance, and just not blindly label it as ataxia. Ideally, in an older child, it is possible to do the other maneuvers also, but in an encephalopathic child or a younger child, the differentiation becomes very difficult.
Yeah.
Hello.
I'll ask a question. Yeah, he's here. Okay. Why don't you ask a question, Arjun?
Yeah, the first question, I think she just answered. Thank you for the answer. But I guess the pathway for cerebral ataxia is absolutely different from what we described in NMDR. In NMDR, technically our nigrostriatal pathway should be affected for us to get the choreoform movements or the dyskinetic movement, which are very perseverative in nature, and they tend to overlap with the stereotypic movement, the same pathway, very repetitive in nature. Whereas in cerebral ataxia is basically the loss of control and the modulation of the muscle smoothing effect, which gives you the imbalanced system. Whereas in NMDR, the choreoform movement or the dyskinetic movement, which tend to intrude on the action potentials which control the muscle, which gives you the imbalance. So technically, it is not really an ataxia, but the imbalance as a result of choreoform movements or the dyskinetic movements. And my second question was, would it be correct for us to call the patients, to say this is an oculogyric crisis, when the essence of oculogyric crisis has to be a very spasmodic, dystonic movement, whereas the upward gaze, intermittent upward gaze associated with the orobuccolingual dyskinesia that we see in NMDRE is technically not spasmodic in nature. They're very repetitive and stereotypic in nature, and they may be perseverating, but they are never spasmodic. What do you think?
I really like the long term that you gave in place of oculogyric crisis. What I read and what I think is that the spasmodic contraction is often described because there is dystonic crisis being described in NMDR receptor encephalitis. So similarly persisting blepharospasm is being described. So it's not it going by the same mechanism, by a different pathomechanism. The even oculogyric crisis can occur, but yes, again, it's something like the ataxia should not have the chorea component causing a false interpretation. So similarly, the point is still there that if it's not a persistent dystonic up gaze, not fitting into oculogyric crisis, the actual phenomena what you said could be there. So I think the key is that whether to identify that if there's a sustained muscle contraction or there is a sustained abnormal posture, whether in the limbs or in the eyes, to qualify for that.
Yeah, the point I wanted to just remind is people tend to describe many phenomenologies just based on very loose terms. So as we continue to describe in such manner, we may lead to more confusion in the sense that the perseverating movements that we tend to see in NMDRE are never spasmodic, although they may be dystonic, but they're not technically spasmodic. They're repetitive rather than persistent and consistent.
Point taken. I think we'll move on.
Thank you.
Thank you, Kard. Thank you.
Thank you, Dr. Rani.
Yeah. Just one question from one more from Dr. Vishwanathan from Chennai. I think he's asking Gauri about in the past there used to be these long ACTH kind of used to have a protocol which went on for a year, and he's wondering whether ACTH should be used or methylprednisolone. Is there any evidence favoring one over the other?
So in this recent international guidelines, they have given all the three options. You can give methylprednisolone pulses every month for a year. You can give oral dexamethasone every month for a year, for 6 months to 1 year, depending on how. If you have 2 months of remission, you can stop whatever you're doing, no matter what you do. Or you can use this ACTH protocol also. All three of them are supposedly equal. Maybe there's a slight edge for ACTH. That is just 1 or 2 studies. Slight edge for ACTH, it looks like.
Anybody else on the panel wants to ask any questions? Kavita, you have a couple of questions. If you would like to just put your video on and ask, because I think you have some experience with, with I think NMDR as well as with OMA. Can you please tell us? Unmute yourself. Unmute yourself.
Yeah, I'm actually in the hospital. There's some background noise. So There are no specific questions as such. What I understood from the OMAS protocol is that some steroid has to go. It can be DEXA, it can be ACTH, it can be methylpred. So the steroids form an important part of the regime of the upfront or the escalating protocols. And with the steroids, of course, we add IVIG and Rituximab either together or stepwise. So that is what I understood from the. And as rightly pointed out by you, we had a recent case where we could pick up a neuroblastoma only on the DOTATEC scan. So I think it would be really prudent to advise DOTATEC scan in any child who's coming to us with OMAS. His even MRI was normal, and we had done a 3 Tesla MRI. And this child actually presented with just ataxia initially, and then started with oxycodone. And the other point I wanted to make was that these children who are even after neuroblastoma removal, as Gauri rightly said, was that the immunotherapy is required for the neurological symptoms. And it may, even after the neuroblastoma removal, whatever those antibodies are, whether we are able to detect them, name them or not, these are the ones which give rise to a lot of chronic neurological sequelae. And that's the reason why we need to give this protocol. And we had one patient whose neuroblastoma was removed 2 years back, and he remained in the state of a lot of hyperactivity and behavioral problems. And only after we gave him Rituximab, even after 2 years, we could control all his symptoms, and now he's almost back to his normal self. So yes, these can be very disabling, though the neuroblastoma has already been removed a long time. So that would be my comments. Thank you so much.
Anita, any comments, any questions?
No, first, excellent talks from everybody. The OMA one, I think we reviewed our 20 plus patients, and we felt that aggressive initial therapy with the steroid, the IVIG and the Rituximab gave you the best results as fast as possible. We are waiting long-term picture, but I gather the long-term prognosis will obviously be better because you control the psychiatric, the neuropsychiatric aspect, the speech and the cognition gets improved much faster. The other thing I wanted to ask is the role of PLEX. We've started, now that you're more comfortable with PLEX in children, we've started using it a little earlier, and we've just had an NMDA who responded to methyl and IVIG. But the minute we did the PLEX, eventually 3 weeks later, everything just disappeared within the first cycle. So maybe we should start being a little more confident and comfortable with PLEX as an initial methylpred with PLEX, and then maybe an IVIG, or I don't know, as we go. Just that. Thank you.
Yeah. Everybody feels, Gauri, that Trump is right and not Macron.
Yeah.
Go on, Gauri, you were saying something.
Yeah, I tried to review the role of PLEX in OMS. There were just very small reports, and there was no head-to-head comparison for PLEX versus IVIG. But all the protocols keep mentioning you can use that. And sometimes it seems to work when IVIG doesn't work. I don't know how it does that, but it does work. And then I also tried to look for head-to-head comparison of Rituximab versus cyclophosphamide. I couldn't get a single good report of that. There's no trial head-to-head. Yeah. The PLEX, another thing I wanted to mention about PLEX is we had one GBS it was, and he was really poor. And when we tried to do the cost analysis, actually PLEX turns out to be cheaper in children less than 30 kg. When you calculated the cost, it came out much cheaper. You just need somebody who can do it. Overall, it comes out much cheaper. You could save about 30,000-40,000 rupees with PLEX. So that's one thing which is unexplored. I agree with Anita. It's unexplored. I mean, less used. You should become more comfortable with it.
Okay, I think we have come to the end of a very exciting and a very informative program. I learned a lot, and I'm sure most of you have also. Vinay, Vishal, and of course Nirmal, please do the honors. What do your comments, please?
Yeah, I think it was really a wonderful session, and I would like to thank Professor Nirmal Surya to take this initiative, and then as on behalf of IAN Pediatric Neurology subsection, thank IAOCN to come on board, and Anita and Kavita for helping us, and then as Udani sir as the person who is behind the whole efforts. And I think it was a great success. We had around 120 to 130 people, and on a Sunday morning means it's a great success, and all the talks were really good. Thank you all. And Kavita.
Yeah, so in the end, I think I'll thank everyone, all of you. We had excellent participation, and thank Dr. Vinay and Dr. Udani sir for thinking about this session, and Professor Surya sir for initiating this under the IAN as a collaboration with AOCN. And on behalf of AOCN and everybody, I thank all the faculty for sparing their valuable time today on Sunday, and it was really reciprocated well by good participation from the audience. So thank you very much.
Thank you.
Yeah.
So thank you all. It is a team effort between Indian Academy of Neurology, Pediatric subsection, and AOCN. I must apologize for this wrong spell before. Good session, very, very interactive, wonderful lecture by all of you. And I could see that many adult neurologists were engaged, and they were asking the questions. So in all, it was a wonderful. Not only that, I just want to let people who have missed the, they can log on to there were more than 20 people access this, even if somebody has missed, and you can also let people know that if they have missed out, they can log on to the YouTube and listen to the talk. And I must thank Rajesh Udani and Aita Hegde, KP Vinyan, and others who have helped us out to have this interesting, successful session. Thank you very much.
Thank you,
Thank you very much. Thank you for allowing us to go ahead with this. Thank you. Good morning and good night, everyone. Good morning, everyone. Have a good day.
Thank you.
Bye. Bye. Bye.
Bye.
Thank you, sir. Bye.